All right. Welcome, everybody, to the 5th Annual Participant Appreciation Celebration of the Stanford ADRC. I'm Mike Grachus. I'm associated with the Imaging Corps. Victor Henderson's going to be joining us in a little bit. He's our principal investigator. We have a really exciting afternoon of talks and appreciation to share with you guys. And without further ado, we can get started. The first session, we have really compelling talks from Kian Yunus on vascular dementia. Carla Abdel-Noor is going to talk to us about Lewy body disease. And then Jeff Nerschel from neuropathology will talk to us about the importance of brain donation and autopsy. So with that, why don't you take it away, Dr. Yunus?
Sounds great. Thank you, Dr. Grachus. Let me share my slides. All right, do you see the slides okay?
Now we can see them, yes.
Wonderful. Wonderful. Hey, thank you, everyone. Thanks for attending, and thanks for the opportunity to present. It's really a great honor to present to our participants today, who are very generous with us. I'm going to be talking about vascular dementia, and I have no disclosures, although it's important to mention that I'm biased with my own hypotheses and some other hypotheses by other scientists, similar to many researchers. The outline of my talk, I'll be talking about the epidemiology of vascular dementia, definition, and the impact on cognition, as well as vascular imaging. So the dementia has emerged as one of the leading health problems of our time. The World Health Organization estimates that 50 million people live with dementia, a number that is anticipated to triple by 2050. Every year, 7 million new cases of dementia are diagnosed, imposing a tremendous burden on families, primary caregivers, and society. Vascular dementia is generally considered the second most common subtype of dementia after Alzheimer's disease, accounting for roughly 20% of dementia cases in North America and Europe, with somewhat higher estimates around 30% in Asia. Vascular disease increases as we age. Both incidence and prevalence increase as we age. This data from the famous Framingham heart study, where individuals have been followed for 50 years, shows that if you start at 65 and look at men and women, and look for the likelihood of stroke or dementia, what we see is that for women, the likelihood is almost superimposed over dementia, and the fact they're co-occurrent. In men, it's more likely to have a stroke than dementia. So the reason I show this is to kind of say that vascular disease is very important cause of cognitive impairment and dementia. So what do we mean by cerebrovascular disease and vascular disease in general? Really, it's any disorder of cerebral blood vessels. There are 3 major and 1 autosomal dominant causes: arteriolar sclerosis. So this is a normal blood vessel, and then you see the lumen, there is the intima, and there is the smooth muscles that allows the vessel to contract. And then there is arterial sclerosis, which is the cause of idiopathic hypertension, which we say idiopathic because we don't really know what's the reason behind it. But you could see as this middle layer, that smooth muscle is getting thicker, which is basically causing high blood pressure, or also kind of vicious cycle with that causes high blood pressure and eventually worsening cerebrovascular disease. The other cause is atherosclerosis. So you see here where this intima gets impacted, and then lipids and other toxic metabolites go underneath and causes this atheroma. Another causes include cerebral amyloid angiopathy, where the amyloid protein accumulates in the walls of the vessels. And then the much more or less common is CADICIL, where proteins accumulate in the vessel wall due to a genetic mutation in Notch 3 mutation. These cerebrovascular diseases cause cerebrovascular injury. So we use terms like hemorrhagic stroke or ischemic infarction. And here you see examples of a hemorrhage in the brain. That's a big hemorrhage. And these are so any black is really blood here. So you see these smaller hemorrhages or micro bleeds. So two different types of diseases, and they present with different manifestations clinically. And there's this ischemic on the lower side where you see this wedge-shaped cardioembolic stroke. This probably came from the heart. That's different from this strategic stroke or lacune that is most likely due to hypertension. And in contrast, you see here multiple strokes, what we call multiple infarcts or multi-stroke dementia. And then there is this just white matter disease that could be silent. So there are different types of cerebrovascular injuries, and cerebrovascular disease and then injury are caused by vascular risk factors. And here we see some of these risk factors. As we get older, we are more likely to get stroke, but more importantly, we are more likely to get cerebrovascular disease and dementia. Just a little bit about the history. When Alois Alzheimer's in 1900s defined Alzheimer's disease, dementia was thought to be caused by predominantly hardening of the arteries. Vascular fractures were considered a major player in dementia well into the 20th century, until in the 1980s, the amyloid beta peptide was identified as pathological hallmark of Alzheimer's disease. Shortly after, mutations in the amyloid precursor protein gene were identified in familial forms of Alzheimer's disease. Since then, the emphasis shifted from vascular dementia to Alzheimer's disease. However, community-based clinical pathological studies revealed that the largest proportion of dementia cases have mixed pathology, comprising features of AD as well as ischemic lesions. These developments have promoted an interest to gain a better understanding of how vascular brain lesions affect cognition and how vascular pathology and neurodegeneration interact to amplify their respective pathogenic contribution. The term vascular cognitive impairment and dementia has been proposed to encompass all people with cognitive impairment of cerebrovascular origin. VCID forms a spectrum that includes vascular dementia, mixed Alzheimer's disease with vascular component, and VCID that does not meet dementia criteria. The prevalence of VCID is high, and this entity is poised to become the silent epidemic of the 21st century. Clinically, vascular dementia could present with post-stroke dementia. So a person could get a stroke and then after that develop a dementia syndrome. And that usually is characterized by a stepwise cognitive decline, just like a ladder. A person gets a stroke, gets worse, and then they stabilize, and then they get another stroke, and then they worsen, and then they stabilize again, and so on. That's different from an Alzheimer's disease that's usually more gradual. So another way vascular dementia presents is that people may have silent strokes or covert strokes, where these strokes happen over time without specific symptoms, and then suddenly, basically, the person starts having the symptoms kind of become more detectable, and they present with dementia. When you look at their imaging, you see that they have a significant amount of vascular disease. And both present with an executive profile, usually meaning that there are impairment in multitasking, organization, planning skills, and relatively spared memory, although you do also see memory problems as well. There are also neuropsychiatric and motoric symptoms in people with vascular disease, including depression, apathy, slowing of gait is also common in patients with cerebrovascular disease. And may lead to syndromes described as lower body Parkinsonism. So Importantly, though, vascular disease plays an important role in what we call Alzheimer's disease or Alzheimer's disease pathophysiology. So pathophysiologically, new experimental findings have revealed a previously under-recognized functional and pathogenic synergy between neurons, glia, and vascular cells. So together called the neurovascular unit. The vascular contribution of VCIT are characterized by the aging neurovascular unit failing to cope with biological insults due to systemic and cerebral vascular disease, proteinopathy, including Alzheimer's disease, metabolic disease, or immune response, resulting in cognitive decline. This figure presents examples illustrating how pathology originating from peripheral vasculature or the heart could lead to cerebral vascular abnormality or affect cerebral blood flow and disrupt neuronal activity and increase risk of dementia. Arterial stiffening as a result of loss of elasticity in large blood vessels could lead to cerebral vascular damage, including pericyte injury and endothelial dysfunction, which in turn causes blood-brain barrier breakdown and neurovascular unit uncoupling. Heart failure could cause chronic cerebral hypoperfusion, an important risk factor for dementia. Atrial fibrillation could increase risk for stroke, which is known to cause dementia. In addition, there's tremendous heterogeneity in the pathology of dementia. So you could see that. So this is a great data from the Rush group, where vascular. You could see that that these kind of light blue is what pure AD is, but you could see that the big chunk is actually mixed dementia, so Alzheimer's disease in addition to vascular dementia and other neurodegenerative pathology. So this study also from the same group looked at the attributable risk of Alzheimer's dementia as people pass away, and you look at their brains. Alzheimer's disease only explained 41% of their cognitive impairment, whereas other pathologies, including vascular pathology, explained the remaining, although not. So here you also see that with dementia. So this is looking at patients after they donated their brains, and there are some people who passed away. This is a community-based study. Community dwelling older people. So people who died with dementia, they significantly had more mixed pathologies, meaning that they have Alzheimer's as well as infarctions and Lewy body and other proteinopathies in the brain. Whereas people who passed away without the diagnosis of dementia, they did not have any of this, they had less mixed pathology, whereas their AD and infarction risk pathology was comparable. Really interestingly, when you put all these pathologies that we know about in the model, or at least the more common ones, in a statistical model, you could only explain about 41% of the cognitive decline in people, whereas there are some residual decline that we don't fully understand. This is So there are these vascular risk scores that we kind of use to kind of predict or try to understand how much vascular risk the person has. So here you could see age and sex, but also cholesterol, education, BMI, blood pressure. They're all included here. And then there's this actually. This study showed really a linear relationship between the sum total of these features and the likelihood of dementia. This plot here demonstrates an interaction between the Framingham Heart Study cardiovascular disease risk score. So when you include all hypertension, high cholesterol, kind of lipid levels, and diabetes, and in addition to the amyloid burden, the amyloid protein being the Alzheimer's disease hallmark, you could see that the interaction was significant, meaning for tau, in the inferior temporal cortex, such that combined higher vascular risk score and elevated amyloid burden was associated with higher tau burden in this region, possibly indicating a synergistic effect for the vascular risk factors and Alzheimer's disease or amyloid on tau. And here you could see where that elevated risk translates to where higher tau was accumulated in this on this image. And here they actually looked at high blood pressure alone, so as a risk factor with amyloid burden. And you could see in this green that people with combined hypertension and amyloid positivity show the worst decline in their memory scores. This is how white matter disease looks, and we could actually measure it, and you could look at the volume of it. So here, this is only a snapshot, so it looks kind of not too much, but when you actually look at it in 3D, you could imagine that this is kind of significant in the brain. It's like you could think of the white matter as the highways in the brain that imagine you're connecting cities and the highways are interrupted, so that will cause traffic, that will cause executive function or slow speed, slow processing, and that's what really we see in patients. These are some clinical trials that looked at that made interventions. So this is the Sprint Mind study, which basically compared intensive blood pressure control. So lowering blood pressure less than 120, and they showed that actually lowered the risk for mild cognitive impairment, although this was not the study's primary outcome. There was no significant effect on dementia, so the primary outcome, dementia, was not significant, but it did reduce the risk for mild cognitive impairment. And this is another study where they controlled blood pressure as well as other risk factors, but they also had lifestyle interventions. And you could see in where people, when you over 2 years, people were less likely to have cognitive decline. And now I'd like to discuss the glymphatic system a little bit. These are newer hypotheses where we actually basically the hypothesis that the brain is clearing this amyloid and tau protein all the time, and it clears it with the vessels. The vessels are really important component there. In a young person, there's this flow that helps these proteins, the yellow and pink blobs, to get cleared. And in older people, the flow becomes a little bit slower. And then Alzheimer's disease, there's this accumulation of protein within the vessel, or this not exactly the vessel, this is the space around the vessel, that called expanded or called perivascular space. But when we see it, we call it expanded perivascular space. And basically here you could see this vicious cycle where there's more blood, more accumulation of these proteins, and the flow of clearance is slowed down. This is how we kind of see them on the MRI. So these are not strokes. These are just like an expanded perivascular spaces. And we could actually measure them automatically. So when we did this with some Alzheimer's disease patients, we found that in late age of onset Alzheimer's disease, the higher their perivascular space volume, the higher their tau level. And that was not the case in the early age of onset Alzheimer's disease cases, which is thought to be of like a pure form with less vascular contribution. So when you actually look at the function of these people, the ones who have higher perivascular spaces are doing better on functional and cognitive scores. So we think that these perivascular spaces could represent an active disease or a form of a brain that is trying to compensate, but eventually fails. So we're thinking about ways to help this clearance system in the brain, help it to kind of clear more of this protein. But in general, just going back to talking about the treatment of vascular cognitive impairment, there are we use blood pressure medications. If you have high blood pressure, diabetes management, statins, cholesterol, blood thinners, and in some cases we use the same medications that in Alzheimer's disease if we see that there's some cognitive impairment. In addition, that is beyond what the stroke could explain. We typically don't use memantine, we don't recommend it, and we definitely recommend lifestyle modifications. And I will end with this slide that basically is from the cardiac literature that shows how the curve was bent after many of the trials. So that's what we need to do in Alzheimer's disease, to bend the curve as well. I hope I'm on time, maybe a little over.
Thank you, Dr. Yunus.
And yeah,
Maybe one quick question, and then if you'd kindly introduce Dr. Abdul Noor after.
We don't have any immediate questions. There is one for the open forum, so we can always move to the next speaker right now.
sounds good. So allow me to introduce Dr. Carla Abdul Noor. She is going to present on the diagnostic process in Lewy body disease, the role of assessment tools and biomarkers.
Thank you very much for the kind introduction, Kian. I'm going to share my screen now. And before starting directly with the presentation, I want to talk to you a little bit about myself. So in addition, So in addition to being a neurologist, I'm also a big fan of the space program exploration projects. And this is a photo of me in the Kennedy Space Center in 2019. And I'm a big fan of these projects because they show that we can dream big. I mean, if we can put a man on the moon, I think we can achieve anything if we work as a team. And I know that we are mostly familiar with the astronauts. This is a photo of the Apollo 11 crew, but actually to put a man on the moon, it took a lot of people to work. And we know that over 400,000 men and women were involved in this project, and over 20,000 universities and industrial firms were also involved. So that is a lot of people. I also think that if we were able to do that, we can also do the same to end dementia. I'm a neurologist and a researcher, and I know that by myself, I'm not going to be able to find the answers to end dementia. We need a multidisciplinary team, and a big part of that team is the patients and their caregivers, because you are the ones who know what are the important questions that we have to look for answers to. So I thank you very much for your contributions. So today I'm going to talk about the role of assessment tools and biomarkers in Lewy body disease. But before talking about the current biomarkers, I want to talk to you about the Lewy body disease definition, and we will start with that. So actually, Lewy body disease is 3 diseases. And those diseases are Parkinson's disease dementia, and dementia with Lewy bodies. And we think about it as a continuum. And when we talk about Lewy body dementia, we refer to Parkinson's disease dementia and dementia with Lewy bodies. And I'll be focusing in the tools that we have to diagnose these 2 diseases. But first, let me show you what is the difference between these 2, and also why we call them Lewy bodies. We call them Lewy bodies because when we assess the brains of the patients that die with this diagnosis, we see these inclusions in the neurons, in the cells in the brain, that are called Lewy bodies because they were first described by the doctor called Friedrich Henrik Lewy. I'm going to stop sharing for a minute because the slides have taken life by themselves and I don't know why. So I'm going to share again just because I can have control of the slides and they don't have control over me. Okay, great. Okay, so I was talking to you about these two diseases. And here I don't want you to read this slide because this is a lot of information and I know that the font size is very small. But I want to show you that for the diagnosis of these two diseases, we have criteria in place and we look for clinical signs and biomarker abnormalities to actually make the diagnosis. In the case of Lewy body, in dementia with Lewy bodies, what we will see is that dementia will occur before or concurrently with Parkinsonism, but in the case of Parkinson's disease dementia, the dementia will occur in the context of a person that has Parkinson's disease. I'm going to stop again. So I'm sorry, I don't know why the slides go by themselves. Going to stop here also. Like, how can I? Okay. Now I'm here. Sorry for the technical issues. Okay. We were here, and so I was telling you the difference between Parkinson's disease dementia and dementia with Lewy bodies is what symptom occur first. In the case of dementia with Lewy bodies will be the cognitive symptoms, and in the case of Parkinson's disease dementia will be a slowness of movement, rigidity, or tremor. Now I'm going to explain you the current diagnostic tools and biomarkers in Lewy body dementia. But first, let me explain you why we think it's important to diagnose patients with Lewy body disease. And this is important because it's not infrequent. Actually, it's the second most common cause of neurodegenerative dementia, but we often don't diagnose the same percentage of that. We actually diagnose a very small percentage of patients in the clinic. And we know that these patients have worse health indicators when we compare them with patients with Alzheimer's disease. These patients have higher mortality rates, have higher functional impairment, higher impact in quality of life, also higher healthcare costs. They are admitted earlier in nursing homes and have higher rates of hospitalization. So this is why it's important to make the correct diagnosis and differentiate patients with Lewy body disease, Alzheimer's disease, and other type of the neurodegenerative dementia. They have different characteristics and they have different prognostics or disease progression, and that's why we made the differentiation. In addition to the clinical criteria that we apply, another tool that we use is the neuropsychological assessments. And in patients with Lewy body dementia, we often see executive dysfunction. And that means that these patients will have difficulties in planning, in problem solving, in finding words, or in judgment, and they also often have visual spatial and visual perceptual dysfunction. That means that they will have difficulties in evaluating objects in the 3D space or identifying colors as well as identifying patterns. They can also have memory impairment, but this is more often seen in patients with Alzheimer's disease, and another characteristic will be difficulties in attention. With regards to language is usually not affected, so these patients comprehend language and are able to maintain a conversation normally. Now I'm going to show you some imaging and electrophysiological biomarkers. One of these biomarkers is the relative preservation of the middle temporal lobe, and I will explain what I mean by that. So when we evaluate a patient with cognitive impairment, we usually ask for a CT or MRI scan to rule out secondary causes of the cognitive impairment. But there are certain features that can help us to differentiate between these neurodegenerative diseases. And one of these features is this preservation of the middle temporal lobe. So this will be an image of a healthy person, and this part here in the rectangle is the middle temporal lobe. And as you can see here, this is the brain, this is a normal size, and this will be here a patient with the Alzheimer disease, and there is atrophy, there is loss of brain tissue here. And the patient with Lewy body dementia, we have a relative preservation, and it's more similar to the healthy person. Another neuroimaging technique that we use is called DAT scan, and that imaging, here we use a contrast that will help us to see the amount of dopamine that is in a region of the brain called the basal ganglia. Here there is an image of a healthy person, and you see a coma shape of the basal ganglia because the amount of dopamine in this region is normal, and this is a patient with Alzheimer disease. And this patient also is more normal, but in the patient with Lewy body dementia, the uptake is reduced, the uptake of the contrast is reduced. And that's because this patient have a loss of dopaminergic neurons in the brain, the neurons that produce this substance called dopamine. Another contrast that we use help us to study the metabolism and the perfusion of the brain. So this will be a normal imaging of a person that doesn't have a neurodegenerative disease and the metabolism is normal. But in a patient with Lewy body dementia, the metabolism and the perfusion will be lower in posterior parts of the brain, in the occipital lobe. Another imaging technique now in the thorax, the mediastinum, where we can see the heart, is this technique that uses a contrast called methiodobenzyl-guanidine, and that contrast goes to the muscle of the heart. This is a person that is healthy, and you can see here the uptake of that contrast is preserved, as well as in a patient with Alzheimer's disease, but in a patient with Lewy body dementia, that contrast is lost and we cannot see the uptake in the heart. We also use electrophysiological techniques, and I will explain you two. One is polysomnography, that help us to confirm if the patient have REM sleep behavior disorder. And I will explain you what I mean by that. So when we are asleep, we have to be paralyzed. That is atonia, we don't move. And there is a period during sleep that is called REM sleep when we dream, when the actually dreaming happens. So we should be paralyzed when we are dreaming. But patients with REM sleep behavior disorder will move and will enact the context of the dream. And we can identify these alterations with this technique called polysomnography, where we put electrodes in the scalp to record the brain activity, and also electrodes in the muscle to record the muscle activity with the electromyogram and electroencephalogram. And with the alterations in this technique, we can identify if the patient have REM sleep behavior disorder or not, which is a typical characteristic of patients with Lewy body dementia. We also can see some characteristic features in the electroencephalogram, the electrodes in the scalp to record brain activity, and those features are usually abnormal signals in posterior areas of the brain. Now I'm going to explain some future biomarkers that are not currently for clinical application, but are under investigation. And one of them is trying to identify the protein that is inside these deposits that are the Lewy bodies. That protein is called alpha-synuclein, and we all have that protein in our bodies, but for some reason, in some people, that protein loses the configuration and starts to clump together causing these Lewy bodies. It's very difficult to try to identify this protein in different tissues or biofluids because it's in very low concentration, but we have developed a technique that is called serine amplification assay that now help us to identify this protein that is very specific for these diseases. And where are we now investigating this new technique, where we are using different biofluids as blood, cerebrospinal fluid, also tissues like the skin, the submandibular gland, another biofluid that is saliva, and the olfactory mucosa. From all of these, the most promising results come from the cerebrospinal fluid. And the cerebrospinal fluid is a liquid that surrounds the brain and the spinal cord and is inside these cavities that we have in the cranium that are called the ventricles. And we can obtain this liquid with a lumbar puncture, which is a very standard procedure. And now there are very promising results that will help us to identify alpha-synuclein in cerebrospinal fluids of patients that have Parkinson's disease or dementia with Lewy bodies. But we are also trying to develop radiotracers or contrast that help us to identify where in which areas of the brain this protein is being deposited. And this is being studied in Parkinson's disease, but we are not there yet to see where are the deposits of alpha-synuclein in Parkinson's disease. The most promising result is in another disease that is also caused by the deposits of alpha-synuclein, that is called multi-system atrophy. And here you have an example of a person that have this disease, and you can see here the deposits of alpha-synuclein in the brainstem and the cerebellum. And this is a person that is healthy and don't have any neurodegenerative disease. We're also studying how different copathologies interact with each other. As Dr. Kian said previously, actually patients with dementia and neurodegenerative diseases have different diseases at the same time, so they are very heterogeneous. And in the case of Lewy body dementia, we know that about 50% of cases of these patients will also have Alzheimer's disease pathology, up to 30% of patients will have vascular disease, and only about 20% are actually pure cases. So since we have very good biomarkers for Alzheimer's disease, we are studying these biomarkers in patients with Lewy body dementia to see how these two pathologies interact to cause a specific clinical profile and a disease progression. We're also studying digital biomarkers, and these will be devices, apps, or remote assessment that can be performed more frequently to have a more continuous information about the patient. Because currently a lot of biomarkers are done at one time point, but we miss the information in between. And with digital biomarkers, we could collect continuous information. So for example, we could use watch to assess sleep, or we can try to identify patterns in speech. And with these behaviors, then we can link that to the different biology of the patients and try to identify biotypes. So in summary, I will finalize by saying that Lewy body dementia is actually two diseases. When we refer to that, we talk about dementia with Lewy bodies and Parkinson's disease. The difference between these two is that dementia with Lewy bodies, dementia will occur before the motor symptoms, and in Parkinson's disease dementia, the cognitive impairment will be after the diagnosis of Parkinson's disease. We think that the cause of these disorders is the deposit of a protein that is called alpha-synuclein in Lewy bodies in Lewy neurons. We have current diagnostic tools that help us to identify the characteristic profiles of these patients from the neuropsychological point of view, but we also have imaging techniques and electrophysiological techniques But we are working on new biomarkers to identify this protein that is called alpha-synuclein in fluids, tissues, and in neuroimaging. And also we are trying to develop new digital biomarkers to have continuous information about the patients. And now I would like to finalize with this quote by John F. Kennedy that talk about why we chose to go to the moon. And we chose it not because that was going to be easy, but because that was going to be hard, but that was a challenge that we were willing to accept and one that we intend to win. And I feel the same about ending dementia. Thank you very much.
Thank you so much, Dr. Abdel-Noor. That was a wonderful talk. Do we have any clarifying questions for Dr. Abdel-Noor, or any pressing questions, Talisa?
Yeah, we did get one question. So the question is Lewy body dementia the same disease process occurring in different parts of the brain as Parkinson's disease?
Well, this is a very good question. And when I can say about yes, we think that what happens in terms of differentiating the processes, I will tell you the differentiation, which part of the brain are affected. So I think that in patients with Parkinson's disease, the deposits of alpha-synuclein are more in the brainstem, and in medial areas of the brain, and in persons that have dementia with Lewy bodies, these deposits will be more in the cortex and the areas that are more related to the cognitive function. So that would be some differentiation. The thing is that we cannot make that differentiation in vivo because we cannot see yet that spatial distribution of alpha-synuclein in vivo.
Great, thank you.
Thank you. Was that it?
Yes, for the immediate questions.
Oh, okay. Thank you. Carla, would you like to introduce our next speaker?
Sure. Then it's my pleasure to present Dr. Jeff Nerschel, who will talk about the importance of brain donation and autopsy.
Hello, everyone, and thank you for being here today. So I am a neuropathology fellow, so I work at the end to make the diagnosis, and I also do research. So there's a lot of us here at Stanford and elsewhere who are physicians and scientists, and I think that's a really great, way to make use of the incredible gift that you all give us for allowing us to work with you and your families. So brain donation is really the final chapter, in any person's dementia story. And it's important for a number of reasons. All of the tests and imaging done, during life, if you get all that, but you don't get the pathology, it's like reading a book without reading how it ends. Because we can't make the diagnosis definitively until autopsy evaluation. And so that's sort of one of the main contributions, as well as research to further our understanding of dementias and Alzheimer's, to research new therapeutics, biomarkers, and then education to teach the next generation of physicians and scientists. As I said before, we can't really know what the diagnosis of dementia is, what the true cause is, until we look at it under the microscope. And that's because the biology of these diseases is defined by proteins that we can't see until we get under the microscope. And then we can grade the severity of the changes that we see. And oftentimes, as has been alluded several times, we see mixed pathologies. So it's not just pure AD or pure Lewy body disease. It's a mix of many different things, where each patient, can be unique and have a unique spectrum of changes. We've gone over before sort of all of the different types of causes of dementia. the major types being Alzheimer's, Lewy body disease, vascular. There's more, and Parkinson's disease. There's more rare forms, frontotemporal lobar dementia, some familial and special forms. And often what has come across in the literature is that we see more than one pathology at once, some vascular with some Alzheimer's with some Lewy body disease, and really knowing what the final diagnosis is critical to make use of those radiology imaging biomarkers, to make use of the blood and serum biomarkers, because if we don't know how the story ends, we can't understand what blood test can diagnose it before, diagnose it during life. So we need that signal, that diagnosis from the end. This is what it looks like. It can look like under the microscope. So one example concretely of how brain donation has already furthered the science and medicine of Alzheimer's. As mentioned before, historically, Alzheimer's was thought to be due to vascular or other causes, or just something unknown. Because people had donated their brain to science, years ago, decades ago, we discovered that amyloid beta is one of the key pathologic hallmarks that we see in Alzheimer's, as well as these tau neurofibrillary tangles. And because of those donations and the research that was based on them, we now know that amyloid and tau are key features of Alzheimer's at the cellular level. And now, as you may know from some of the news stories, there are antibody and other targeted therapy directed at amyloid and tau. And none of that would have been none of that would have been possible if we didn't have the brain donation and tissue to do these studies. Similarly with Lewy body disease, because past generations have donated their brain to science, we were able to find out that alpha-synuclein differentiates Lewy body disease from Alzheimer's and frontotemporal dementia. And now there are biomarkers and tests that look for alpha-synuclein. But again, we have to sort of understand at the cellular and tissue level in order to get those targeted drugs. And frontotemporal dementia, most often due to TDP-43. And there's also some link with amyotrophic lateral sclerosis, Lou Gehrig's disease, also having some TDP-43 pathology. Mixed pathologies are frequent, particularly in older people. This is just a pie chart showing that in patients with a clinical diagnosis of Alzheimer's disease, when the final pathology was shown, we actually see only a third of the pie chart had pure AD with nothing else, whereas another third had Alzheimer's with some alpha-synuclein, and a quarter or so had some TDP-43 and synuclein. And similarly, Lewy body disease, over half of patients with Lewy body disease had some degree of Alzheimer's amyloid beta protein change. And again, this is really important to know because these new therapies that are coming out are targeted at the biology, targeted at amyloid, tau, future TDP-43 or synuclein. And if we don't know, how the story ends and whether it was amyloid or synuclein, we don't know if the treatment sort of had worked or had slowed it. So it's really providing that final answer. When you have more than one disease process going on, it can sort of cause an accelerated decline. And understanding and diagnosing patients with mixed pathologies is important because in the clinical trials that we do for Alzheimer's, we want to be, with highest confidence that it's AD and ideally pure AD or as close as it can get, because you don't want to treat, a Lewy body alpha-synuclein disease with amyloid therapies, because that's just treating the wrong thing. And if you do a clinical trial that, has patients with Lewy body disease or dementias that don't have amyloid or tau, obviously they're not going to respond because the biology is different. Now, it's not just patients with dementia that we need. Healthy donors are also a really important and valuable part. And that's for a number of reasons. research over the past several years has shown that there's a surprising number of cognitively normal, just everyday, elderly patients who have varying degrees of amyloid, tau, and synuclein. And this raises a really interesting question. Since they're normal cognitively, what is special about their immune system, their biology, their genetics or biochemistry that sort of allows them to compensate and not be affected by those pathologies? And we can only address this by studying normal patients with and without, and then dementia patients with varying degrees of pathology. And so this is a really exciting area of research into resilience. What makes people resilient? And that's really one of the goals of a lot of Alzheimer's and healthy aging research, is that we want to allow sort of a healthy aging process, to enjoy your retirement and not have these issues, and have sort of the longest health span of healthy life. More concretely, these brain donations are helping dementia research sort of actively right now. I'm in neuropathology, but I'm also a computational researcher interested in machine learning and artificial intelligence, and working with the excellent computer science groups at Stanford. We're using artificial intelligence to revolutionize the pathology diagnosis from scores that were defined decades ago to use more intuitive and important ways of subtyping Alzheimer's. And importantly, once we have a better subtype of the disease and classification based on the ground truth gold standard pathology, then we can link that information with their radiology, blood, and CSF tests to hopefully allow those biomarkers to find sensitive and specific markers that can allow us to diagnose earlier. On the left here is just an image from a hippocampus, the patient with dementia, and then a schematic neural network that is taking the image, making predictions, and trying to identify features that distinguish it from the normal individuals. I'll also mention one of my mentors and colleagues, Dr. Inma Kobos. She's a neuropathology attending and a physician scientist as well. She's using genetic and tissue and biochemical approaches to study why some neurons are more sensitive to disease versus more resistant, and what makes neurons resistant, and how can we improve resistance. And so they use this tissue and they isolate single cells, both with the pathology and without the pathology, and then do complex genetic analyses, dimensionality reduction, and also machine learning techniques to identify what makes different subtypes of neurons able to resist the pathology and survive longer than others. And so here's just an example of some of the bioinformatics approaches they do with the genetics. This is from 29 donors, including both healthy controls and Alzheimer's. And each one of these small little dots here is one single cell from a donor brain. And then it's colored by different cell types. So within your brain, there's dozens or hundreds of different cell types. And using kind of the new era of big data and computation and machine learning, we're better able to parse apart the biology changes that's happening on the single cell level. And using that information, we can find ways to hopefully make neurons more resilient, find out why neurons might be vulnerable, and hopefully slow down that process of neuronal loss and memory decline. And so these studies, hopefully we can identify some early events, identify ways that can protect and repair neurons, and eventually develop new therapies. Just acknowledgements of some of the additional people at the Neuropathology and Brain Donor Program. And at this point, I'll be happy to take any final questions or comments.
Yeah, so one question did come through. So part of our study, we do encourage donating eyes also along with the brain. Can you tell us a little bit about how important donation of the eyes is together with brain donation?
Yeah, so that's something that we have been starting. We have some excellent ocular pathologists here, and the reason asking for the eyes are really a window into our brain. Part of the retina, part of the eyes contain a lot of neurons, and the goal is, if we understand how Alzheimer's affects the eye, which has not been studied in detail, perhaps we can use additional imaging techniques during life to look for eye biomarkers for Alzheimer's. And so we don't really know, the research hasn't been done on what sort of changes Alzheimer's causes in the eye, but we do know that other processes that affect the central nervous system can also involve the eye. And so we're hoping to help define biomarkers that might be specific to the eye, that maybe you could go get an eye exam and have some estimate of risk, or be able to evaluate for early signs of amyloid or tau or synuclein pathology.
Great, thank you so much. And then I know Nusha has stepped away, so I guess we can move on to the next. I guess the next part is the open forum here. So we do have a few questions. I'll first go to Dr. Yunus. I'll just kind of rotate a few questions out to some of the speakers. So Dr. Yunus, one question came through asking if you could discuss the importance of various types of exercise for individuals that have been diagnosed with neurological disease. In particular, is there any evidence that it slows the progression of diseases, or does it simply elevate the general physical health of the individual, masking the effects of the disease?
Yeah, absolutely. This is a great question. So the exercise that we recommend is something that increases the heart rate and breaks a sweat. So it's basically cardio in general. It helps when you I think there are two different mechanisms that this exercise could help with. The first is generating these factors that help rejuvenate the brain, helps these cells kind of become more healthy. So we're not just talking about the health of the body itself, the physical health. That exercise helps the brain itself. Another is when you have that elevated heart rate, allows the brain to clear these kind of products that we all produce. As you could imagine, this is really difficult to study and tease apart because there are so many different variables. But yes, there is evidence that cardiovascular exercise helps the brain in some ways. It's one of the good evidence that we have there. It's still in some cases contested. Some people some studies show that exercise doesn't really significantly help, or once the disease starts, then it doesn't significantly improve. But I think there's the evidence shows that it's the best thing we could do so far to prevent cognitive decline or getting into stages of neurodegenerative diseases. There is some evidence for physical exercise like weightlifting, basically, as well. And I think the benefit is like multitudinal. There's so many different ways you prevent yourself from falling. When your physics are good, memory gets better after exercise. There's after that finger study finding, now there are many other clinical trials that are trying to prove this more conclusively. But I think my recommendation is definitely yes. This is one of the best things we can do to help our our brain health. The recommended exercise is about 30 minutes a day, 5 days a week, something that kind of It's not just walking, maybe like climbing a hill or stationary bike, things like that.
Great, thank you so much. And we do have a few more questions, but it looks like Dr. Henderson, the director of our Stanford ADRC, was able to get on. So I want him to kind of jump on for just a moment here. Let's see, I can. Are you able to unmute Dr. Henderson? Are you there?
He might still be having some difficulties, so maybe we can go on to the next question while he gets.
I'm going to see if I could try to help him
Okay.
unmute since I'm the host, and I apologize for this technological snafu. Unfortunately, we cannot add Dr. Henderson now because we went live before all these technological issues set in. So I'm being told by IT that we're unable to add once we've gone live. Sorry. Isabel, were there more questions?
Yeah, there
Okay,
are more
yeah.
questions. I
So
think
I'm gonna see, maybe take one more question and I'll see if I can unmute, or you want me to see if I can unmute him now? Sorry.
whatever works. There's a couple more questions if you want to work on that for
Can you
a
ask
minute.
one question and I will
Mhm.
see if I can unmute him, but ask him to wait, please. Thank you.
Okay. Let's see. Okay. So this question is for Dr. Abdunnoor. I don't think I said your name right. I'm so sorry. There's a few questions for you actually, but let's go with one of the first ones that came in. Can you tell us a little bit about why it is important or helpful to know which type of dementia a person has?
Yes, this is a very good question, and I alluded a little bit about that in my presentation. And I think it's important to know the type of dementia because the different types of dementia have different symptoms. They appear in different stages of the disease, and they have different progression rates. Also, patients will have with the type of diseases will respond different to medication. So if we're going to apply some type of intervention, for example, we know that patients with dementia with Lewy bodies sometimes have, they show more side effect to a type of medication that are the antipsychotics. So we have to be aware of that. And to do that, we have to know if the patient have dementia with Lewy bodies or not. So I think that that's the main reason, because these different diseases have different characteristics and the patients might respond different to medication. Also, if we want to find treatments that eventually could cure them, we have to characterize them very good in life to include these patients in clinical trials or other research studies.
Great, thank you so much. Okay. Were we able to get Dr. Henderson?
I don't think so, Talisa, but you can ask another question. I think we have a good amount of time.
Okay, so the next one will go to Dr. Nerschel here. So if you could just kind of give us a quick recap about what you're hoping to learn by obtaining the brains of study participants. I know that for many, they're pretty reluctant to go through with this process. So just kind of reminding them overall how this is helpful and important to the advancements of science for us.
Yeah. Yeah, I mean, it is a very, personal and big decision. It really is a gift for future generations to be able to work with the brain and study it to understand Alzheimer's better. So I'll go back to the first point from the presentation. It can help families with a definitive diagnosis. The diagnosis based on the clinical and imaging is not final Alzheimer's until it's diagnosed on pathology. And we see that oftentimes a clinical diagnosis may come in and the diagnosis on pathology may be mixed, oftentimes mixed or maybe somewhat different. So the clinical diagnosis is it can help provide closure for a final diagnosis of the disease process that was going on. In terms of research and education, having this tissue, as I said before, is really critical to developing treatments for future generations. Amyloid beta, was first shown to be one of the key pathologies in Alzheimer's back in the 80s. And if we did not have the tissue to do that, we wouldn't have the new drug that sort of is in phase 3 clinical trials now that's targeting forms of A beta. So it's taken a while to get there, but this type of therapeutic generation is really not possible until we can understand in human tissue what's going on at the cell and tissue level and what the pathology is specifically. Again, we can't make progress with the biomarkers until we know the final answer. All of the other, studies and visits and testing, prior to a brain autopsy is very important, but without that final diagnosis, it's like reading a book but not knowing how it ends. And all of those, biomarkers and stuff don't have much meaning unless they're tied to a very specific pathologic diagnosis. And so that's kind of broadly what we're hoping to do. And more specifically, within our center, we're looking at the relationship among mixed pathologies, Alzheimer's, Lewy body disease. How can we detect those earlier using imaging and fluid biomarkers? How can we leverage new techniques in genetics, in computer science to diagnose earlier and more effectively?
Perfect. Thank you so much for that recap. That's very helpful. Let me see what other questions we've had come in here. Okay, so this one again is for Dr. Abdelnour. This question is asking, are there differences in the location of alpha-synuclein inclusions in the brain? Are those different in different types of Parkinson's, such as a tremor dominant or medication resistant or other types of Parkinson's?
Yes, so the deposition of alpha-synuclein is different in the different Parkinsonian syndromes. So there are different types of diseases that, as I mentioned, that have the deposition of alpha-synuclein, and these are Parkinson's disease, dementia with Lewy bodies, and multisystem atrophy. And it seems like the type of the protein, the configuration, the misconfiguration of the protein is different between these three diseases, and the areas of the brain where this protein aggregates is also different. I'm not aware specifically about the different Parkinsonian subtypes. I don't know if Dr. Yap have more information about that, but I know that between these three types of alpha-synucleinopathies, that we call them because they are caused by the deposition of this protein, have different configurations and different spatial anatomical distribution in the brain.
Great, thank you. And this next one is also for you. So knowing that in dementia with Lewy body individuals, that they have so many eye-related deficiencies, besides completing neuropsych evaluations, are there any other tests available that can be requested when having a refraction that may be helpful in the diagnostic process, such as a visual field exam or other tests?
Yeah, this is a very good question. And one thing that we always recommend to patients with dementia in general when we do the recommendations is to also evaluate the sensory system, and one of the systems is the visual system. So if there are abnormalities in the visual, but in the part of the eye that we can correct if it's a refractory dysfunction and we can correct that, that will help the patient to see better and to decrease the abnormalities that they may have by trying to see if there are abnormalities in the 3D space. But the neuropsychological aspect that I was talking about during the presentation, or the dysfunction that we see, is more caused by the dysfunction in the brain, and not is like an eye problem. It's because the occipital areas of the brain that are related to trying to understand that information, the visual information, don't work correctly, and that's why they have this visual spatial or visual perceptual dysfunction. Of course, if you also have problem in the eyes, that will be increased. So that is why you have to rule out that and treat that if that is present.
Okay, great. And I think there's still a couple more for you if you're okay answering a couple more here. So as far as doing deep brain stimulation surgery, what other type of symptoms is this surgical procedure recommended for other than tremors, if any?
So deep brain stimulation is currently being studied. It's more in the research area. It's not recommended, but it's being studied for also neuropsychiatric symptoms and for depression. So maybe in the future it will be used for that. But currently, I think the typical pattern of typical patients that will benefit is the patients that have more a traumatic subtype of Parkinson's disease.
Okay, and then the last one here for you that I'm seeing is asking about the most common side effects of amantadine, and could you recommend an alternate medication?
So there are several possible side effects of amantadine. Those are dry mouth, constipation, nausea, vomiting. Patients can feel more drowsy. So what we recommend when those side effects are not tolerable, we can, there are different types of medication that target dopamine. This could be using a different formula that has levodopa and other medications in it, because there are different formulations for levodopa, or we can use dopamine agonists. There are also inhibitors of enzyme called monoamino oxidase. So we have a lot of different medications that target the dopaminergic system, and we can use them in as an alternative to amantadine.
Great. Thank you. And then I think the last one that we have for now is for Dr. Yunus. And this is kind of more of a personal question from a participant. And they're asking, they started taking atorvastatin for sinus medication or for sinus difficulties and discovered that they felt fuzzy. And they were wondering if this is something that you that you do come across as atorvastatin causing fuzzy thinking.
Atorvastatin, meaning the cholesterol medication, to my knowledge, it's not used for sinus issues. It's cholesterol medication. In terms of side effects,
oh wait, sorry, I did read it wrong. They're taking it for cholesterol, but they were taking that with their sinus medication. But I don't. Yeah, sorry, you're right though.
I mean, it's hard to answer on an individual, quickly without knowing exactly who the person is and what is the context. But generally, this is not a common side effect. Medications, statins in general could cause you to feel fatigued sometimes, could affect the muscles, but not necessarily that specific symptom that you mentioned. So it's not a common side effect, but definitely it's possible. So we'll have to review with your primary care, whoever mentioned, and kind of give that medication. You could sometimes taper it down and see if the side effect goes away. There are alternatives for sure, but I mean, yes, these atorvastatin and other statins could, people do complain of sometimes non-specific side effects or specific symptoms.
Okay, great. Thank you. And Nusha, I think that's all the questions that we've had submitted for the first half here.
Thank you, Talisa. So I'd just like to take a few minutes of everyone's time, and then maybe as I'm talking, let me pose what I'm going to be referring to first, so you have time to respond, maybe in chat or Q&A, and my team members can let me know. We had a break scheduled a short break from 2:40 to 2:45. We can extend that break. I would be more than happy to lead us in some Qigong exercises and mindful breathing. I was telling the IT tech, I think I definitely need it after trying to troubleshoot these issues with trying to get Dr. Henderson on board. So just feel free to put it in the chat or something, and somebody can text me and let me know. Because I'm recording, I'm trying to be mindful of not doing that. So on behalf of Dr. Henderson, I just want to extend his heartfelt, how do I say it, sadness in not being able to join us directly. He really, really wanted to be able to interface with all of you, our wonderful participants and care partners and family members, for your graciousness in giving your time, for volunteering for the study, for continuing to stay with us. And we are so deeply grateful for all that you do, all that you give in time and energy and spirit, as well as all the contributions you make towards the science. I think, Carla, thank you so much for sharing what you did. This is definitely a village, that it's going to take a village, and you are a key aspect of that village as our participants. So we are deeply grateful. And of course, I'd also like to go ahead and take a moment and thank all the speakers we have already had: Dr. Kian Yunus, Dr. Carla Abdul-Noor, Dr. Jeff Nerschel, as well as those yet to come. So we still have some wonderful talks awaiting you. And I'd also like to take a moment, since I didn't have the opportunity at the very beginning, to once again welcome you all to this Participant Appreciation Day, and also to say I'd like to extend my heartfelt thanks to the clinical core team, Isabel, Talisa, Veronica, Gabriel, Nicole, Maria Lucia, Mohini, Alejandra. Now I'm losing count of Nora. Did I get you all? So Isabel, Veronica, I hope I got you all. I hope I didn't. I hope I mentioned all of you. You've been phenomenal. Oh, and Alyssa, for helping out with this special event today. And of course, again, Dr. Henderson, I hope you can be patient and understanding with us. We did our very best to try to get you on here so that you would have an opportunity to share your thoughts with the group. So let me see if we can, he's on video now, I heard. Okay, maybe he can. Let's see.
I don't know. Am I audible?
Oh,
Yeah, we
can hear
fantastic.
You're
Yeah.
Victor, you're
Well-
sideways, but we can hear you and see you sideways.
Maybe sideways for now is good enough. So we're working at one of the most technologically advanced universities in the world, I'm told. But IT abandoned me and said he's done all that he can do. And video services hasn't gotten back. And so I'm on my phone, and I wasn't able to hear the presentations that went on before. And I'm so sorry I missed those. And I did hear Nusha's very kind words, and I echo them completely. We are so grateful that all of you have been helping with the study. We're grateful to our staff and our coordinators and our researchers and our investigators for making all this possible. And I hope to be able to join you for the second half of this Appreciation Day. So my great apologies. I wanted to be here throughout, and I'm very glad I'm at least here for a tiny bit of it. Thanks.
Thank you, Dr. Henderson. I'm so glad you were able to join us. That's wonderful news. You made my day.
Even sideways.
Even sideways is good. Hey, we do everything we can in whatever way we can, right? That's wonderful. So I don't know. I didn't see a text, so I take it that maybe people might just want a break. But then I would like to propose, if everybody is okay with it, maybe starting 5 minutes earlier, so at 2:45. Ted, Beth, Mike, I hope you're on. Is that okay? And that way we can just get moving a little bit more quickly. Maybe you can either message Alyssa maybe, and then she can let me know and we can begin at 2:45. If that works for everybody, because then that would give us, lovely Ted, thank you. Because that would give us then, I think, a little extra time for the end of the day in case people think of additional questions. We want to optimize your participation, our participants and family members and care partners. We'd like to encourage your participation. And just to again reiterate why we had the webinar, I put it in the emails, but in case you didn't see it, in order to ensure your anonymity, we went this route. So we made every great effort to keep your information confidential, anonymous. And so that's why the webinar format. Unfortunately, that then restricts our ability to interface with you and see your faces and speak with you directly and hear your voices. So that was the technological compromise we needed to make. And I have other things I'll share with you at the very end. So be well, everyone. Even if you want to take a break, I'm going to get up and do a few exercises. And if you'd like to join, you're more than welcome to. Otherwise, let's resume at 2:45. So I'll go ahead and lead a few exercises just to kind of get us up off our feet. And then I did hear the question about exercise. I will tell you my own personal bias. I think it helps resolve a lot of things in life. So I will just go ahead and do this. Okay. Not to say that it's the end all answer to everything, but it does help us with many of the things such as stress, dealing with emotions, dealing with all sorts of things. So, all right. So for those of you who are joining this part to do some Qigong, I would like to first propose that you take a moment and settle the hands on what we refer to as your lower dantian. So if you were to hook your thumb into your navel or thumbs into your navel and just let your hands drop, this part, the lower part of the hand is referred to as the lower dantian, which is your storehouse of your vital life force energy. So Qigong, Qi is energy, Gong is the craft or skill of working your energy or moving your energy. And that's what this practice is. You can have your feet completely together or slightly wide apart. Go ahead and allow yourself to get still. And by the way, you can do this seated. Just make sure that you're evenly, your sits bones are even on your chair, and you can just sit in your chair. And go ahead and take a few deep breaths here. So you inhale through the nostrils. Exhale through the mouth. Inhale through the nostrils. And exhale through the mouth. I decided the music is not necessary. And one more time. Now you can step your foot a little bit wider, so you're hip width distance apart, and go ahead and let the hands loose. And people will call this wild horse trembling, wild horse shaking, but just start to shake from the feet up. So this is a wonderful exercise to kind of loosen up any stagnant energy or anything like that. But especially, I used to work with children quite a bit, and I noticed children do this when they get very agitated. And actually, this is something in Qigong, which is meant to kind of release pent-up energy, pent-up emotions, pent-up things. One of the things you might notice is if you keep letting your hands kind of shake, they'll start to feel a little bit fuzzy. And that's a good thing. That means the nerves are working, things are kind of, the messaging is happening in our system. Now go ahead and bring the hands like this. And you might notice that don't let them touch, but if you bring them close together and then slowly pull them apart, there's almost like this, whoa, electromagnetic field that you can feel between your hands. And that's qi, that's your energy. Go ahead and turn it. And if you go slow, you can feel it even more. Take a nice deep inhale and allow that to go into your lower dantian. Let's go ahead and inhale up. Exhale down. Bend the knees, tuck the belly, tuck the pelvis slightly. Inhale up. Exhale down. Inhale up. Really slow, very slowly allow that exhale. As if your hands are like droplets of water, washing, cleansing you of the toxins and other pollutants and other things that don't belong to your system. And you can release that. So for those that might have some lower back issues, just go more gentle on these. Don't bend as far. But another one is like well, this is a spine opening exercise. It's really good to kind of get the spine to release and actually the cerebrospinal fluid in your system. So you can inhale, exhale, fold forward. Inhale up. Very slight bend backwards, but here you're going to exhale and you're going to just tuck the chin slightly and look up so that you don't hurt your neck. And your shoulders kind of pull apart. Inhale. Exhale, bend forward. Inhale up. Exhale gently back. So this is a great one for the thoracic region, for those of us who work on computers and everything. That's really good. I do this a lot. Exhale forward. Inhale up. Exhale. And down. Because I want you to be able to have time for a break, I'm just going to go ahead and close us. And then we'll be back at 2:45. So inhale, reaching up. Exhale, bending the knees, tucking the pelvis and the belly. Slowly exhale down. See if with each inhale and each exhale, you can expand the inhale, but especially extend extend the exhale. So exhale is always drawing down the hands. And when I say extend, and let the breath come out through the mouth for the exhale, but the breath comes in through the nose for the inhale. Breath is a wonderful way to regulate your system, especially your autonomic system, which is kind of that fight or flight system, even your central nervous system, the busy thoughts, the busy emotions, the fast pace of things. Whenever you really want to slow things down, deep breaths like this, inhale, exhale down. And of course, to slow it down even more, the pace becomes even. It slows down that much faster. I've been practicing Qigong for many years, but if by any chance you feel tingling in your hands right now, that is not a bad sign. That's an excellent sign that you are moving the qi, you are moving the energy, you are getting oxygen, blood, everything flowing well through the system, even tingling in the feet. If you don't experience it, that's not a bad thing either. But if you become aware of that, I just wanted to share that that's a typical experience when one practices these arts. So the last three, you're going to inhale up. The palms overlap over one another. So this is gather the qi. And now we're going to gently draw it down in front of us. We're going to return it to its origin. Here, thumb and index finger connect to kind of seal that into the lower dantian. We will do two more. Change the hand that was on top. It's okay if you didn't do it this time, we'll do it the next time. Again, we will seal. And then inhaling up. Exhaling it. Again, as we started, settle the hands on the lower dantian. Move the left foot to meet the right. So slide it on the earth, don't disconnect from the earth. And just take a few breaths here. They can be inhale and exhale through the nostrils, ideally, tongue to the roof of the mouth. And if you're comfortable, you can close your eyes. And hands in namaste position in front of the heart center. Let us fold into our practice. Namaste. And our Qigong salute. I thank you all for joining. So we have about 8 minutes before we restart. Please go ahead and take a break. So I don't even know if anybody was able to join the little exercises, but hopefully that worked out. So thank you, everyone. Welcome back from break. It is now my sincere.
Cheryl, we can't hear you.
Oh, no. You can't hear me?
No, we can. That's better. Sorry about that.
Oh, wonderful. Thank you, Mike. Well, Thank you, everyone. Welcome back from break. I hope you had a nice break. Again, this is the 5th annual ADRC Participant Appreciation Day, second segment. It is my sincere pleasure to welcome Dr. Ted Wilson, who will be speaking about the blood-based biomarkers for Alzheimer's disease. Ted?
Thank you so much, Nusha, and thank you as well, Dr. Henderson, for this invitation. So my name is Ted Wilson. I'm an instructor in the Department of Neurology and Neurological Sciences here at Stanford, and I've been working with the Stanford Alzheimer's Disease Research Center in the biomarker core. And so over the past few years, while I've been working this core, I've been accessing your de-identified data, the biological samples that have been contributed, the data on neuroimaging, and it really has been a privilege for me to work with this very rich material. I'm very grateful for that, and so I was, very excited to have the opportunity to present sort of some feedback in the opposite direction, and to sort of present to our participants during this appreciation celebration in order to share some of the data that we have, the things that we've been working on. So just as a quick glimpse of some of the work that we've been doing in the research session, I'll be indicating what we have been moving towards in terms of the blood biomarkers for Alzheimer's disease. And just so that we're all on the same page, I wanted to begin by answering what is a biomarker. So biomarker is anything that's objectively measured and evaluated as an indicator of a normal biological process, pathogenic process, or pharmacologic response to therapeutic intervention. So what that means in that case is biomarkers can be used to detect disease, they could be used to stage disease, we can use them to monitor disease progression. And when drugs and treatments become available, we can use biomarkers to monitor treatment efficacy and response to treatment. So in terms of Alzheimer's disease, we use biomarkers to look at the diagnosis and prognosis, but also for screening in clinical trials. And so specifically in terms of blood-based biomarkers, why is it that we're interested in this area? And in Alzheimer's disease, particularly in the last few years, there has been an explosion of research into this area, and it really is an area that's moving very quickly, and it holds a lot of clinical promise. And so some reasons and benefits for a blood-based biomarker or a blood test is that blood collection is quick and easy. And this is in comparison to other gold standard diagnostic methods, such as through the collection of cerebrospinal fluid or through PET neuroimaging. So compared to those, blood-based biomarkers are quick and easy. Blood is promising because we can collect large volumes of it and use it to support many research studies. With blood, we can go through repeated sampling. It's an option. So we can sample over a tight time course of a few hours, or annually we can have repeated blood draws. And relative to other methods, it does not require specialized equipment. This is important for underserved areas or maybe rural areas. And overall, what it does is it opens up the potential for wide-scale screening of at-risk populations. And so here's an image showing some of the work that we do at the Stanford ADRC biomarker core. So on the right, this is Michelle Swarovski. She was a research assistant with us working on analyzing some of the CSF and blood samples. And what we do at the biomarker core is we measure biomarkers, a number of proteins that we've identified, and we make that data available. It's all de-identified, but we make it available to investigators affiliated with the Stanford ADRC for them to use in their own research. So we provide this as a tool for researchers within the ADRC to sort of understand the biological processes and link them to the clinical phenotypes that are observed. Something else that we've been up to at the biomarker core is we're focused on developing new biomarkers as well. So in addition to the established biomarkers for amyloid and tau, we've been looking into other avenues to develop new biomarkers for the use of AD detection and disease tracking. And so this is just a quick little image of some of the data that we've collected and using samples provided by ADRC and Udall Center participants. And so this is very fresh data. So the paper that summarizes this data was just accepted this week. So that will be out in press. And all of the papers, I should mention again, using Stanford ADRC data are those are available on the website. So a great resource to look through and to follow the work that we've been doing. And so here, what I'm showing is that we measured blood levels of a protein called p-tau 181. And so Dr. Nerschel and others had previously indicated that two of the hallmarks of Alzheimer's disease include the presence of the protein amyloid and the presence of the protein tau and their dysregulation. And so what we're looking at is blood levels of tau protein that's phosphorylated at amino acid 181. And this shows up in the blood. And when we measured it across the ADRC participants, we have clinically unimpaired, participants with mild cognitive impairment, and participants with AD. What you can see is that there's an increase in the plasma p-tau levels, the blood levels of plasma p-tau. And so when we divide this group up further, according to whether or not they have the Alzheimer's disease amyloid protein dysregulation, you can see that in the clinically unimpaired, amyloid positive individuals have higher levels of plasma p-tau. And within the mild cognitively impaired participants, the same thing is true. Amyloid positive has higher levels of plasma p-tau. And if looking at the AD, amyloid positive Alzheimer's disease group, we do see high levels. And so what we've done here in the blue line, you can see we've asked a computer algorithm to say, where can we cut these blood p-tau concentration to give us an indication of what's reflected of maybe an Alzheimer's disease process. And here the value comes out at around 2.35. And so in this case, with this blood test, what we would do is say, looking at these data and this concentration, we would probably recommend follow-up evaluation through neurocognitive exams and validation using gold standard biomarkers, so through cerebrospinal fluid analysis or through PET neuroimaging. But together, just at this initial step, what this shows is that this blood test, p-tau 181, does distinguish very well clinically unimpaired participants from participants with Alzheimer's disease, which is very, very promising, very exciting. And so what else we did sort of in this analysis was to look at how well does the blood p-tau protein correlate with other gold standard or already established biomarkers. And so on the x-axis over here, we look at the cerebral spinal fluid or CSF levels of amyloid. And in the graph, the participants indicated in orange are those who are positive for amyloid. But in both the orange and the blue, you can see that there is a correlation between the levels of plasma p-tau, blood p-tau, with the cerebral spinal fluid levels, which is good. And then in the CSF, if we look at the levels of p-tau 181, those are correlating very strongly with the levels of plasma tau 181. And so these data suggest that in this case, plasma p-tau may be a good proxy of what's happening in the CSF. So this blood test may be a good proxy of what's happening in the CSF. And we looked at another measure of Alzheimer's disease pathology. So looking at PET neuroimaging, in this case, amyloid, once again, we do see good correlation between this blood test and what we're detecting with amyloid PET. And so again, in this case, we see that this blood test does correlate well with CSF and PET, and maybe allowing it to be a stand-in pre-screening for these assays. And so in the next couple moments, I'll discuss sort of some other blood tests for Alzheimer's disease that are available. And so we have the tau-based blood biomarker so far. But in development and research, there's currently another test that's used to measure amyloid beta protein. Again, amyloid being very specific to Alzheimer's disease. Another marker that's currently under development and is GFAP. And so GFAP is a protein produced by cells called astrocytes in the brain, and those are very much involved in brain inflammation. And so under circumstances where we see increased brain inflammation, we do see increased GFAP signal in the blood. Neurofilament light is another protein in the blood, and it marks axon degeneration that's taking place in the brain. And the last one here on the list is soluble TREM2 or sTREM2. And this is a blood-based biomarker that's able to reflect brain microglia activity. And microglia are another important immune cell in the brain. And so where we are right now is having sort of an expanded toolbox. And so what we're thinking is that combining p-tau181 with these other blood-based biomarkers here, we might be able to construct a more complete pathological picture in Alzheimer's disease. And that's the ultimate goal. And so in the last minute that I have, I'll answer one of the questions that was submitted earlier. And the question was, well, when will the blood tests for AD be available? And here I'm presenting a review article that was recently published on the appropriate use recommendations of blood biomarkers in Alzheimer's disease. And this was just recently published, but the field is moving so quickly, it's expected to be updated within a couple of years. But essentially, blood tests for Alzheimer's disease are already being used, not in the primary care sort of scenario yet, but they're already being used in clinical trials to help stratify participants and include participants in trials. They're also being used in specialized memory clinics, but only when followed up with other established tests like cerebral spinal fluid tests or PET. And so at the moment, though, more data are needed for the use in primary care. But again, this research is moving very, very quickly. And so with that, I would like to say a special thank you to all the participants and their families. And my email address is here if interested, and thank our collaborators at Stanford and other areas. Thank you very much.
Thank you, Ted. Appreciate it. We're going to go ahead and just go through the talks, and then we'll do questions afterwards. Next, I'd like to introduce Dr. Beth Mormino, who will be speaking about multimodal neuroimaging in the Stanford ADRC. And before you start, Beth, I just wanted to recap for everyone that these three talks by Dr. Wilson, Dr. Mormino, and Dr. Gracious are all in response to the survey I had put out earlier, asking what one of the common themes was hearing about how your contributions, data are being used in the ADRC, and we put this segment together to address that. Thank you. Sorry, Dr. Beth Mormino, please go ahead.
Thanks, Nisha. Can you hear me, and are my slides? Okay, great. So I lead the imaging core at the Stanford ADRC. And in the next few minutes, I'm going to tell you about the multimodality imaging that we've been doing, together with the participants. And I also want to acknowledge the larger imaging core team. So in particular, I don't know if you guys can see my cursor, I want to point out Hillary Vossler, who I'm sure many of you that have recently been scanned with us have interacted with. She's our lead coordinator, and really the core is highly dependent on her. She does all of our coordinations and collection with imaging data with you guys. So we use two imaging techniques pretty regularly in the Stanford ADRC. So the first type is called PET. It stands for positron emission tomography. This technique involves an injection of a radioactive small molecule that binds to a specific target in the brain. So we've been using this a lot to look at amyloid plaques and tau tangles, which we've heard a lot about today, which are core pathological features of Alzheimer's disease. The second technique that we use is called MRI, stands for magnetic resonance imaging. So this is a different principle. It uses a magnetic field, a very strong magnetic field, along with radio frequency currents. And together, it's able to tell us about different properties of brain tissue. And so we actually have many different types of MRI scans that we do that tap into different features of brain tissue. And it gives us the ability to look at both brain function and also brain structure. So this combination of imaging, spanning both PET and MRI, excitingly allows us to look at different features of aging and neurodegenerative disease, how these features relate to each other, which are poorly understood, and importantly, how they change over time in our human research participants. So for example, the slide I'm showing here, when we think about Alzheimer's disease, we tend to think of the amyloid plaque and the tau tangle beginning earlier on, and then after that, we might see changes in brain function and brain structure. So excitingly, imaging gives us this opportunity to test these hypotheses. We've heard about both Lewy bodies and TDP-43 in previous talks, and this is just to point out that we're focused quite a bit on amyloid and tau. They're important for Alzheimer's disease, and also because these tools are readily available now. We unfortunately don't have these disease-specific PET ligands for Lewy bodies and TDP-43 yet, but I would predict that in the near future, we will start to have PET scans that can tell us about the spatial distribution of these pathologies as well. So here are a few amyloid scans that we've collected at our center. This is what we expect from the very thorough postmortem characterization that has already been done that preceded our ability to do this with PET. We expect for amyloid plaques that there's a broad distribution throughout the brain, and that's in fact what we see. So here's to the right is an example of what we would call an amyloid positive scan. The presence of plaques is indicated by these warmer colors. So as you can see, the signal is pretty much spread throughout. And this is in comparison to a typical amyloid negative scan. So somebody with kind of low, cooler signal throughout the brain. Tau PET, however, so tau is getting at these tangles, and as we suspect, again, from the extensive postmortem literature, the distribution is quite different with this pathology. So specifically, we expect the tangles to begin quite focally in the medial temporal lobe before becoming more widespread throughout the brain. And that's in fact what we see with our imaging. So here's one example research participant. They have a positive amyloid scan, so spread throughout the brain. And here is their corresponding tau PET scan, where you can really appreciate the focal nature of the scan. So we see uptake within the medial temporal lobe and then spreading into inferior and lateral temporal lobes. So this is what we see at the individual level. We also know that this pattern early on is quite focal, and then we expect it to spread over time. So that's shown here in these two statistical group level maps. And then we also know that in addition to the pathology spreading throughout the brain, the exact patterns also tend to be inconsistent across participants and tend to match the clinical presentation. So for instance, here are two examples of different types of Alzheimer's disease. Here's an example of an Alzheimer's subset that has a more posterior presentation of tau signal, and that also coincides with more visual symptoms. And then here's a subgroup that has a more left kind of lateral presentation shown here and has more of a language presentation clinically. So here's just one slide highlighting some very recent research that we've been doing here. This is work that's led by Dr. Greg Zaharchuk in the Department of Radiology in collaboration with the Imaging Corps at our ADRC. And so one major limitation with PET imaging is that there is this radiation exposure. And even though the amount of radiation in a single scan, it's quite low, as I've kind of started this talk with, we're getting more and more interested in doing multiple PET scans where we can capture different relevant features. And we're also interested in doing PET scans over time. So if we're interested in all these scans, there's this obvious limitation when it comes to the radiation piece. So this research program has really focused on the question of, can we do a lower dose than normal and use deep learning approaches to deduce the same information? And that's in fact what Dr. Zaharchek's group has been able to show. So that's shown here. So with a scan that only includes 5% of the normal injection, if you use a deep learning algorithm on that low dose data, you're able to extract a similar style of scan compared to the full dose. So this is obviously a very exciting approach, and it's possible that this might change the way that we do PET imaging in the near future, reducing radiation exposure and really allowing more room for additional scans, especially as new targets and new PET scans become available. And then I'm going to highlight one more recent line of work taking place at Stanford. So far, I've only really talked about PET imaging, but here's one example of some innovative work involving 7T MRI. So the 7T MRI system, it's a high field magnet, and it allows us to look at these smaller structures in the brain, given the increased magnetic field strength. So here's work that was recently published and led by Kathleen Poston in neurology and Michael Zene in radiology, showing this ability to get at these small structural changes relevant for Parkinson's disease, and show that these volumetric measures are correlated with various disease features as well. So this study is complete, but I'd like to point out we actually have these investigators are actually leading ongoing 7T MRI approaches that are currently recruiting from the Stanford ADRC. So you might see some flyers about recruitment into one of these sub-studies. So I'm going to end my talk with just reviewing some of our primary imaging goals within our core. So, we are quite excited about the combination of PET and MRI to enable us to examine these different features relevant for aging and different neurodegenerative diseases, and to test hypotheses about the sequence of these events. We believe that this knowledge will help us improve our ability to define risk profiles, to understand heterogeneity in the trajectories of these diseases. As you heard from Ted Wilson too, another application is to help validate some of the work going on the plasma and blood side. And we're also, a primary goal that we have is to integrate these advanced methodologies related to imaging. So I provided two examples, but one goal is to try to use these advancements to reduce barriers to imaging, such as reducing the amount of radiation exposure. And we're always excited about these new MRI techniques that allow increased sensitivity to get at presumably smaller structures and improve our ability to detect initial changes. So I will end there. I want to thank you, for your participation in our imaging studies. I know the studies themselves can be, quite tedious to participate in, but we are scanning so many of you. So I know you guys it seems like you are up for the challenge, and we really appreciate you, interacting with our core. And I put my email here if you have any questions directly for me, but thank you.
Beth, why don't you introduce? And thank you so much, Beth. Can you introduce the next speaker?
Yeah, so our next speaker is Mike Gracious, who's going to be speaking to us about your genomes at work in Alzheimer's disease and related disorders.
All right, so I had to unmute there. Let me share again. Okay, thanks Beth and Ted for two great talks. I think this is a really fun little session to be able to actually look at data from our own participants, our audience today, that is either just recently published or in my case, hopefully soon to be published before too long. So as sort of a refresher, a 2-minute primer on genetics. This is our current understanding of genetics, which is based on something called the central dogma, which sort of came into being about 30 or 40 years ago now. But the notion is that we have DNA here, and DNA is the blueprint for the proteins that are going to sort of do all the work, but they pass first through this RNA stage, so we call this messenger RNA. And the messenger RNA is then translated into the protein, and the protein is usually the thing in the cell that does the work. So we talked about tau and amyloid proteins today, for example. So they start with a gene, the gene gets transcribed into a messenger RNA, and then the messenger RNA is translated into a protein. And what's great about the ADRC, among many other things, is that you guys are helping us at each of these 3 stages. So with a single blood draw, we're able to look at your DNA, we can look at the messenger RNA in your blood cells, and we can look at protein levels like you saw with Dr. Wilson, and I'll show you a little bit of some other proteins that we've looked at. And then just as another reminder, you know, DNA is double-stranded. You see the 2 strands here, and each strand has a big line of bases on it. This is 1 base, and this is 1 base pair. So I'll be talking about single bases for some of this discussion. So there are a whole bunch of different ways to look at genetics. I'll just describe 2 that we use here in the ADRC. One is short read whole genome sequencing. And when we do this, we take your DNA here, it's all bundled up. We break it, we fragment it into little fragments that are about 150 bases in length. And then the next step is to, at each position, determine which base is there, an A, a T, a G, or a C. Then we take those 150 base pair fragments and we line them up against the reference genome, or what we know the genome is supposed to look like. And here's an example of one of our participants' DNA, looking at short read sequencing. And basically each of these gray lines that you see is one of those 150 base pair fragments. And what we do is sort of align them, cobbled together. If we're interested in this particular position in the genome, we can cobble about 30 of these 150 base pair fragments together, see where they all overlap, and make a call at this position. And in this particular case, which is the ApoE4 allele, this participant has 1 copy of E3 and 1 copy of E4. And that's short read sequencing. And that allows us to look at almost all of the base pairs in the genome. There are 3 billion bases across the genome. We can see, you know, tens of millions of them with whole genome sequencing. What we miss, though, with standard whole genome sequencing, which is really focused on single base pair changes. So most people have an A at a position, and if you happen to have a T, we call that a single nucleotide variant. But what we miss with standard whole genome sequencing are larger genetic changes. So imagine you have an insertion of 500 bases just kind of stuck in the middle of a gene, or a big chunk of a normal gene that's deleted, say, 1,000 base pair deletion. What's kind of surprising, it was news to me about a year or 2 ago when I learned this, is that standard whole genome sequencing is really blind to these large structural variants. So we consider anything a structural variant that's basically an insertion or a deletion of greater than 50 bases. And those are really hard to see with standard short read whole genome sequencing. And these are not that rare. So any one of us, or basically each of us, should have about 15,000 or so of these large structural variants. That suggests too that a lot of these structural variants are well tolerated and probably don't mean much. But on balance, if you had to guess whether a 1,000 base pair deletion or a single nucleotide variant change was going to be disruptive, you'd bet on the larger structural variant. And right, so they're more likely to disrupt protein function than these single nucleotide variants. And so what's nice now is that we recently got a grant that allows us to do what's called long read whole genome sequencing, which is what I'll show you now. And we've recently completed this on all of our ADRC participants, at least those that were enrolled up to about 6 months ago. So here again, we take your sort of muddled up DNA on the top. We break it now into fragments, but these aren't 150 base pair fragments anymore. These are long fragments of DNA. The longest on record so far is about 1 million bases long, but we shoot for about 20,000 bases. We still have to determine at each position whether it's an A, a T, a G, or a C, and then we have to align it again to the reference genome. And so here's what long read sequencing looks like. This is the same subject I showed you before. We have both short read and long read sequencing. This is that same ApoE4 position. And now you can see this whole view here is 600 base pairs. And now you can't see where these long read fragments end because they're extending onto either side of this 600 base pair window, as opposed to the short read sequences that I showed you earlier. So with this, we can also still pick up the single nucleotide variant. This is the E4 allele. They have one copy of E4, one copy of E3, but we're also able to pick up large insertions and deletions. And so in the last few slides, I'll just show you some very preliminary data, hot off the presses and still not published, that looks at this gene called, we'll just call it TMEM for simplicity. What's been found is that in frontotemporal dementia, and particularly in frontotemporal dementia that's caused by a single gene mutation on a gene called granulin, variations, single nucleotide variations in this TMEM gene are actually protective against frontotemporal dementia. And it's not clear why that's the case, but it's a very consistent finding. So these are 4 or 5 different studies, all looking at the same single nucleotide variant called RS199 here. And in each case, it reduces the risk of frontotemporal dementia. And here's the TMEM gene now, and this shows you the positions of these 4 different single nucleotide variants. They all, because they're kind of near to each other, these are all inherited. You either have all 4 of these or you don't have all 4 of these. But it wasn't clear why these were providing protection against frontotemporal dementia. I should mention also that although the effect is less prominent, a little less strong, this same set of single nucleotide variants protects against Alzheimer's disease as well. But it's much stronger protection against frontotemporal dementia. So here's what we found. Here's a single subject's short read genome sequencing looking at this particular gene, TMEM. And you can see these little 150 base pair fragments in gray. The whole window here is 824 base pairs. And we don't really see much in this region. However, when we look at the same subject now with long read sequencing, and now you can compare this short read fragment of DNA, which is about 150 bases, to this gigantic one, which extends across the entire window here. And now it's actually quite easy to pick up what ends up being a very large deletion here. So you can see the coverage here drops to about half over this long span. And this is a 320 base pair deletion that we found in this subject, and actually that we found in 40% of our subjects. So this is an incredibly common large deletion on this TMEM gene. And it turns out that this deletion is perfectly co-inherited with all of these other 4 single nucleotide variants. So if you have this, the variant at this position, which 40% of us do, you also have this deletion. And that's true across basically this entire stretch of DNA. So now we're hopeful that this deletion explains or will allow us to understand why people that carry this very common variant are actually protected to a large degree against frontotemporal dementia and to a somewhat lesser but still significant degree against Alzheimer's disease. And then the last piece sort of tying, we talked about DNA, we're skipping the messenger RNA middle ground for the moment, but we will talk about the protein outcome here. And what's been found in other studies is that if you have those variants, those common single nucleotide variants on TMEM, you tend to have increased levels in granulin, which is an important gene and protein for frontotemporal dementia. And what we were able to show now using not just your gene, but your plasma protein. So when you give blood, groups working with Ted and Tony Weiss-Coy are able to measure the amount of protein that you have in the blood. We focused earlier on amyloid and tau, but as Ted mentioned, there are a bunch of other proteins we can measure. And in fact, now we commonly measure several thousand proteins in your blood. And what I'm showing here is the relative level of the protein granulin in the blood of ADRC participants who carry 0 copies of this TMEM106 deletion, 1 copy of the deletion, or 2 copies of the deletion. So you can see that a lot of participants, as we expect, carry this deletion. But what's nice here is that the number of copies of this deletion that you have, 0, 1, or 2, is positively correlated with the granulin protein level. We know that certain patients with frontotemporal dementia get it because their granulin levels are too low. So this allows us to make a pretty direct connection between a structural variant that we would have missed with short read sequencing and plasma protein levels that tie very tightly to frontotemporal dementia and to Alzheimer's disease. So we have a lot of work to do still here, but I think this bodes really well for the value of long read sequencing, which we've now finished on over 400 ADRC participants. Okay, so to wrap up, we're optimistic that this long read sequencing should help us identify new variants that increase or perhaps even more excitingly decrease risk for Alzheimer's disease and related disorders. Having the plasma protein measures in addition to the genetics and long read sequencing really helps us understand how gene changes impact messenger RNA, which I didn't show you, but also protein levels, which I did show you. And lastly, I just really want to reiterate how grateful we are for you guys for putting up so much effort to give so much of yourselves, your time, your tissues, your brain scans. All of it has been incredibly helpful. And I think now we're at a critical mass of over 400 participants, many of you contributing longitudinally, where this data set, this massive data set, is going to really start to bear fruit. So thanks, and I'll just mention my collaborators too. All right, and with that, I guess, Nisha, we move on into the open forum and discussion. Is that right?
Yes, thank you so much, Dr. Gracious. And likewise, Drs. Wilson and Mormino, wonderful talks. Wonderful to hear how all of this data is coming together and all this wonderful work that's happening. So yes, we can open to Q&A. And for this portion, Isabel will be asking the questions. Isabel?
Yes, so we received just a few questions so far, but the first one is directed to Dr. Wilson. This question states it's regarding the blood-based biomarkers for AD. They read about it in the newspaper a while ago, but they've asked several professionals about it, find that those professionals are not familiar with the idea of a blood test for Alzheimer's disease. Perhaps you can speak about when this will be available to patients.
Yeah, sure, absolutely. Thanks, Isabel. And I touched on this briefly at the end of my talk, but I can expand on it a little bit here. So the data that you've probably seen in the newspapers and the headlines through the news, I think what really it's reflecting the research that's come out that's shown that these tests are very positive. And as it stands now, that these tests are really only used in the research contexts, like what we're able to do in the lab, and they're not yet fully validated and available for direct-to-consumer use, like some other maybe genetic tests might be useful for, or even they're not quite yet available for use in primary care. And the reason is that we need more time to collect more data on how well these tests prepare. And we really want to make sure how well these tests perform. And we really want to make sure that we're getting it right before they're released. Ultimately, I think the hope is that these tests are used in that context, where an individual may come to their primary care provider and they may say, hey, look, listen, I have been experiencing these complaints. I think maybe something might be happening. I have these memory slips recently. What do you think? And then in this case, the physician might be able to say, well, why don't we look at a blood test, which we might have available, and that will give us our first indication whether or not there's something that may be concerning or maybe something that is okay, and that's where to go. So as it stands today, the blood tests are only used in research contexts and for use in clinical trials, making sure that we get the right participants into the right clinical trials, but they're not yet used in primary care.
Maybe I'll just chime in with one little, thanks, Ted, sort of caveat to that, which is it's definitely the case that the sort of blood tests that we are used to and that we've seen a lot of data from that Ted's running are not available yet. There is at least one sort of approved blood test that can be sent now clinically that really focuses on amyloid. And the problem with that test is that none of us have much experience with it. It hasn't been vetted as well. So to my knowledge, I certainly haven't. I don't think any of our other providers in the memory disorders clinic have sent this amyloid test, but just so, to sort of clear things up, if you do hear that there's one out there that can be ordered now, that's the case, but we haven't actually ordered it here at Stanford because it's been sort of held sort of tightly to the chest of the company that's been using it. And so I think we're not quite as comfortable with it yet.
Thank you, both Dr. Gracious and Dr. Wilson, for answering that question. The next question was directed to Dr. Mormino. I think it's more of a general study question. It says, Dr. Mormino has mentioned study recruitment. Is there a central conduit for distribution of recruitment information to all of us, so we don't always have to search it out? I think this is coming from the participant's perspective here.
Yeah, I can speak about the imaging flow. So for imaging, we try to capture, so we actually just recently started collecting this PET data. We switched over to PET in 2019. So many folks that enrolled before 2019 may have never done a PET with us. But we're trying to link the imaging to the first visit, because it's helpful to have the visits collected within a certain time window. So that's one kind of side of the imaging, is that we actually have the schedule that follows the other ADRC visits. However, we are recruiting for these different MRI sub studies, and we don't have a central location for all these flyers and all these opportunities. So that is some good feedback for me to hear this question, because I think we could put something like that together for these sub studies. So yeah, thank you for that feedback.
Great, thank you so much, Dr. Mormino. This is a question that was directed to Dr. Wilson, but maybe some of the other neurologists can chime in as well. The question is, Dr. Wilson, what is the relationship between alcohol intake and Alzheimer's disease or other kinds of cognitive decline? Specifically, does alcohol kill blood cells or brain cells? Should this go to another neurologist? That was embedded within the question itself. Or maybe
I'll chime in quickly. Yes, the particulars should go to a neurologist. But I will say one of the benefits of the advent of these blood tests is that we're really now starting to appreciate sort of the peripheral aspects, and we're really starting to understand Alzheimer's disease and other neurodegenerative conditions as whole body situations and scenarios. So in terms of alcohol as a risk factor and other things, the neurologist should speak to that. But in terms of, now we do have these new tools that allow us to better study the relationships between the peripheral cells, for instance, and alcohol. But maybe Mike, or if some of the other.
I'd be happy to weigh in. I'd be a little bit of a wet blanket response, I'm afraid. I mean, there's always, anytime there's an alcohol study in the medical literature, it gets picked up by the Science Times or the Mercury News and spreads like wildfire. First of all, alcohol can be used as a neurotoxin. So, not surprisingly, in sufficient quantities, you can kill neurons with alcohol. I don't think that really sort of applies to how we think about alcohol and the risk of dementia. This is a long, storied, and sort of muddled history. My personal take on it is that when we see dementia in people with chronic alcoholism, it's more likely a result of malnutrition and poor nourishment over usually decades. So vitamin deficiencies, for example, can be quite common in people with chronic alcoholism. This notion that maybe 2 glasses of wine is actually protective, I'm very skeptical of those sorts of studies. I think people that have managed to only drink 1 to 2 glasses of wine for 50 years probably do a lot of other things that make them very healthy and reduce the risk of vascular dementia, for example. They're probably not smokers, they probably exercise. My recommendation in my clinic is, first of all, if you don't drink, you don't need to start, please don't. If you do drink after age 55 or 60, I would work very hard to get down to at most a single drink a night, less than that. It's not great for memory, but it's also not great for balance. We're already at risk for falls as we get older. So don't start if you don't already drink, and if you do, see if you can get down to no more than a nice glass of wine a night.
Great, thank you both. So that's all of the questions we have allotted for this session so far. I'm not sure if Nusha, you think it would be a good idea to move on to the next session?
Sorry, I was just checking with Jenny to see if she might be willing to go a little bit sooner. So Yeah, 3:30 on the dot. Perfect. So that would then also allow us to open up the final forum and panel and possibly even end early. That's fine too. So we'll just see how it all goes. So now it's my sincere pleasure to introduce Jenny Clark. She is our resident gerontologist and has come back time and time again because this topic of caregiving and there are different variations around the topic of caregiving that she is able to address. So today, based on the feedback we had gotten before, she will be talking about unraveling the challenges of caregiving. So without further ado, it is my sincere pleasure to introduce Jenny Clark. Jenny?
Hello, can you see me okay? I think it's a little dark where I am.
You have a beautiful bright shaft of light on you.
Let me see if I can fix, oh my goodness, sorry about that. I'm not sure how I can get that off.
It just shows how
Okay.
enlightened you are, that's all.
Oh my gosh. Oh, I'm sorry about that. I'm trying to fix it. Okay, well, let me share my screen and hopefully you'll be looking at my slides. Or anyway. How's that? Good? Okay. So yes, thank you for having me here today. I'm going to be talking about the challenges of caregiving. And let me advance my slide here. So these are some of the most common challenges or tasks of caregiving. And there are the physical tasks such as bathing, dressing, grooming, toileting, incontinence care, those types of things that I'm sure you're all familiar with. And then we have some of the more cognitive and emotional tasks, such as managing medications, managing finances, coordinating medical care, and providing emotional support. And then there are, of course, many that I haven't mentioned here that I know you all are very familiar with. This next slide is talking about one of the biggest challenges that caregivers face, and it's the effect that caregiving can have on families. So family caregivers often report a lack of knowledge about the disease, and they also feel that they're unprepared in providing care. Caregiver responsibilities have increased at home due to medical advances, and we've seen that over the last 10, 20, 30 years. Patients are discharged home from the hospital much sooner than they used to be, whether that's after having a baby, having a surgery, having a knee replacement, something like that. Perceptions of outsiders can affect how open a family is in sharing the diagnosis. So many times families try to keep the diagnosis a secret, and then in turn, they may not receive enough support from others. Many families struggle to find coverage, and they struggle with the financial aspects of caregiving. They also struggle with end-of-life decisions, and many are unsure of available resources. Caregivers oftentimes become isolated, and they stop participating in groups or social events that they used to be involved in because they need to be home and taking care of the person with dementia. And also, caregivers can be so overwhelmed and exhausted that they don't have energy to go out and socialize. Other challenges that many caregivers face are financial in nature. 78% have out-of-pocket costs related to caregiving. Those can include medical visits, medications, in-home care, special food for nutrition and hydration, durable medical equipment, and home modifications. And in the workplace, a caregiver loses wages if they cannot work and they have to stay home to provide care for someone. A Pew Research study found that 39% of American adults are family caregivers, and of those, 70% are working. And then there's also the emotional and physical stress of caregiving, which can affect job performance. And there are the increased health costs for caregivers because of the toll that caregiving has on a person's physical and emotional state. And then there are also health challenges that caregivers face. So caregiver burden is a measurable term, and that encompasses the emotional, physical, and financial challenges of caregiving. And then overall, caregivers have lower levels of well-being and physical health. So many caregivers have cardiovascular and other diseases resulting from the persistent stress of caregiving. Caregivers have low self-care. They may eat less healthy foods because it's easier to grab something that's pre-made or delivered or something to go. because it can be difficult to get to the store. There may be a lack of diminished exercise routine, and there usually is a lack of sleep or interrupted sleep. And we know that over time, this can cause or can negatively impact the brain, the heart, and overall health. The psychological challenges of caregiving include mixed and varied emotions, including some of these here. One of the hardest parts of providing care to a person with dementia is that there's oftentimes a feeling of loss for a very long time. Progression with this disease can be slow, and it's very difficult to watch someone decline over a long period of time. So we're going to switch gears a little bit and talk about the caregiver and their unmet needs. And it is very important for medical providers to consider the caregiver as part of the care team and to offer a caregiver assessment to better understand the caregiver's level of burden, their current state of health, their needs and preferences, and their goals. When a caregiver's needs are unmet, the caregiver may experience burden or stress, which can lead to emotional and physical aggression for the person that they're caring for. And even if a person with dementia has an impaired ability to understand verbal communication, they can pick up on that tension, anger, or stress from body language. Also, if a caregiver is not well supported and becomes more socially isolated, the person living with dementia also becomes more socially isolated, which can increase the rate of cognitive decline and reduce well-being and quality of life for both the person living with dementia and the caregiver. One of the best ways to support the caregiver and the person with dementia is to develop a care plan, and we'll talk about that in some future slides. So here's some main domains of caregiver needs: self-care, emotional support, respite care, care planning, and education. And unfortunately, as we all know, the COVID pandemic has severely impacted many of these resources, but hopefully some of them are starting to reappear, and I know they are slowly. Caregivers need time, space, and energy to practice their own health management and in their own individual way. So mindfulness, counseling, support groups, attending to their own medical needs, and enjoyable exercise can help increase their well-being. And here at Stanford, we have a couple of free resources, and I think that these were sent to you in your packets, but we have the Neuroscience Supportive Care Program, we have the Stanford Health Library, and the Caregiver Program. And you can find all of those on our Stanford websites as well. Education and care planning are key to supporting caregivers, and there's some national organizations listed here at the bottom of the slide. And then respite care is also a necessity for caregivers. And you can look at these organizations on the bottom of this slide as well, and that will give you some links to some respite care. Respite care can also be provided through private pay through home care agencies, adult day programs, state-funded programs such as the Area Agency on Aging, and in California, the in-home supportive services through Medicaid or Medi-Cal, and then also through friends and family. Caregivers can be seen as an intervention in dementia care if they're seen as playing a crucial role in the quality of life of the person living with dementia. So one meta-analysis showed that family caregiver interventions had a larger treatment effect on the difficult behaviors caused by dementia than antipsychotics did. And multiple research studies have shown that person-centered care as a caregiving intervention reduced difficult behaviors. In one study of 15 nursing homes, 289 residents had reduced levels of agitation because the staff used person-centered care techniques. So you're probably asking, what is person-centered care? It is recognizing the whole person and honoring their preferences and personality. It's seeing difficult behaviors as communication of unmet needs. It's supporting engagement in activities that are meaningful to the person living with dementia and not necessarily meaningful to the caregiver. It is including the person with dementia in decision-making and care planning to the greatest extent possible, and also leveraging the remaining capabilities of the person with dementia and encouraging independence, and offering the person with dementia the dignity of risk, which balances providing opportunities for autonomy and independence with supporting safety. And oftentimes we talk about caregiving in dementia. We talk about how to best support caregivers and offer tips and tricks on how to manage some of these difficult or challenging behaviors, such as denial, aggression, crying, screaming, non-compliance, and others. That's very important, but it's also important to help caregivers understand why a person who's living with dementia has behaviors that are sometimes very challenging. And we know that a person who is living with dementia still has strengths and abilities. They still have preferences and a personality, and they have the ability to be engaged in their lives. So we need to try to understand why these difficult behaviors are occurring. And essentially, it is our job, the job of caregivers and medical providers, to see these difficult behaviors as communication of unmet needs, because the dementia that the person has may cause them difficulty expressing themselves with words. So we need to try to understand or identify the unmet need. And it could be that the person with dementia is hungry, maybe they're dehydrated, or they're in pain or discomfort. The medical team or the caregiver could be communicating poorly. So we could be talking too fast or too low of a tone. The person with dementia could be experiencing a lot of stress. We may be rushing them or treating them like a child. The environment could be too noisy, too cluttered, too hot, or too cold. Or maybe what we're asking them to do is too difficult, or there may be too many steps. So all these things can cause frustration. And when a person has the diminished ability to logically make sense of their environment or the task at hand, the person living with dementia can become very agitated or irritable, causing what we consider a difficult behavior, but what they're considering communication. Another possible cause of unmet needs is loss. And our culture tends to look at a person living with dementia as no longer able to do things for themselves. Therefore, we take away a lot of opportunities, tasks, and experiences from the person living with dementia. People with dementia may experience the loss of any of these listed here: cognitive abilities, such as mastery in a field or occupation where they worked for a long time, mastery of self-care tasks like brushing their teeth or using a can opener. They may no longer feel independent because they're always being told what to do and can't make decisions for themselves. They may feel a loss of productivity because they're no longer given opportunities to do things for themselves. One question to ask is, have they had the opportunity to add value to their life or to anyone else's life recently? There could be loss of communication. They may have trouble finding words or knowing which words to use. They may forget names of important people in their lives. Oftentimes there's a loss in relationships. Sometimes friendships will dissolve because friends don't know how to handle the changes that they've seen in the person living with dementia. And they may be experiencing a decline in well-being and quality of life. So once the unmet needs or losses for the person with dementia have been identified, then the caregiver can respond to the person with dementia's needs by using person-centered care in the following ways. We can enhance communication by using more eye contact, keeping our eyes at or below the level of the person with dementia so we don't create a power struggle. We can use soft touch and talk with a clear and caring tone, so not too loud, not too soft, and to not speak to the person with dementia like they're a child. We can create a safe environment free of tripping hazards and clutter. We can help to increase or decrease stimulation in the environment. We can simplify the task that we're asking the person with dementia to do. So we can communicate with one direct statement or use yes or no questions. We can also offer more time for a response. Sometimes we don't give the person with dementia enough time to respond or enough time to process what we've asked them. And so we've already asked them another question. We can provide the opportunity for meaningful activities for the person with dementia. So it doesn't matter if that activity is meaningful to us or to the caregiver. It needs to be meaningful to the person living with dementia. So you may see someone holding a baby doll or a stuffed animal, and to us that may look silly or we may think that's inappropriate. But if they're engaging with that, then they are getting meaningful feedback and probably a positive experience from that. And we can allow the person with dementia to make their own decisions and to have choices and self-determination as much as is safe and possible. And one of the best ways to support the caregiver and the person with dementia is by helping them develop a care plan. So the goal is to optimize function and quality of life for the person with dementia, and then to offer support and education and respite for the caregiver. Care plans should be personalized and include some of the following: a structured daily schedule with meaningful engagement, cognitive stimulation, and exercise. The care plan should address proper sleep hygiene, a healthy diet, and medication management. There should be ways to reduce safety risk, including maybe wearing an emergency response pendant or a watch that will automatically detect falls or locate a person if they get lost. Also, to ensure that homes are safe, checking on carbon monoxide detectors and smoke detectors. And then if someone's driving, you could get a driving test or ask their medical doctor to discuss that with them. I know how much they love to do that, but that is important. And then also to have someone overseeing finances and medications and to assist with care coordination, medical appointments, follow-up visits, those types of things. And then caregiver burden needs to be addressed and proper supports need to be put into place for those caregivers, such as support groups, family meetings, home visits, reaching out. There are a lot of not a lot, but there are some doctors that will do home visits, social workers, geriatric care managers, and those are usually private pay. Then on a positive note, before we end, I just want to highlight a couple stats from the National Opinion Research Center regarding the rewards of caregiving. 83% said that a family caregiver said that overall caregiving was a positive experience. 75% said that the experience strengthened their personal relationship with the care recipient. 50% said that the caregiving role gave them a sense of purpose or meaning. Many adult children are glad to give back to their parents who once took care of them. And a lot of spouses and partners stated that if the situations were reversed, they know that their spouse or partner would do the same for them. And some cultures take honor in caring for their loved ones, so that was seen as positive or rewarding. And then in closing, I'd like to share this quote from Rosalind Carter. There are 4 kinds of people in the world: those who have been caregivers, those who currently are caregivers, those who will be caregivers, and then those who will need caregivers. So at some point, caregiving will touch us all. Here are some references and then my contact information for any questions. And please feel free to contact me if you have a personal question, or I think we are going to take some questions now as well.
Thank you, Jenny. That was great as always. Very helpful.
Thank you. I think Dr. Henderson was trying to say something.
Oh, okay.
Were you trying to say something, Dr. Henderson? I just saw your name pop up.
No.
Okay.
Am I audible?
You are.
No, again, I apologize for not being able to join more directly, but I've enjoyed sitting back, hearing the last presentations and just seeing the marvelous job that you and Isabel are doing and making things run smoothly. So carry on.
Okay, thank you. Talisa, I think that was directed at you. So if you
And
can go
Talisa.
ahead, if you would kindly go ahead and open up the panel discussion. It would be Drs. Henderson, Dr. Yunus, Dr. Abdul Noor. I did ask Dr. Gracious if he would like to join as well, if he's available, and then Jenny Clark as well. Before we do that, just thank you all so very much, all of our speakers. I wish we could all give you a big round of applause, but I will do that now. And then go ahead, Talisa, it's all yours.
Okay, and we did get quite a few questions, which is exciting. So just a reminder to the speakers, if you can be pretty brief in your answers, so we can try to get through as many as we can.
Is not available. At the tone, please record your message. When you have finished recording,
sorry,
you may
Alyssa,
hang
I
up
think
or
you
press.
are muted. There you go.
Okay, there we go. Sorry about that. Okay, so we'll just kind of cycle through here. So we'll start with one for Dr. Yunus. Could you discuss any significant breakthroughs in the treatment of neurological diseases made in the last year or two?
Yeah, absolutely. So there are a few monoclonal antibodies. These are antibodies that are injections specifically for Alzheimer's disease that go attached to the protein and try to clear from the brain. It's a little controversial. There are side effects like brain bleeding or brain inflammation. And there are more medications that we're going to hear about in November. So there will be some like end of November at the CTAD conference. So I think there is some hope, but there is a lot of controversy. These medications are not meaningful in terms of how much they help. So basically, the improvement was like about 0.5 on a scale out of 18. So that's really clinically not meaningful for patients or caregivers, although statistically it is reported that was positive or significant. Where FDA has not told us if they're going to cover it yet, and then or if they're going to approve it, and then Medicare, we don't know if they're going to cover it. So I think the field, there's so much in the field these days, but we still don't have a final kind of clear answer yet. And if someone else wants to add, I'd love to hear Dr. Opicius or Dr. Henderson's.
Yeah, and is my disembodied voice coming through?
Yes.
Yes, it's a great question, and we're focusing in on Alzheimer's disease, but I think that's appropriate. And I want to reinforce what Dr. Yunus has said, that there are a number of companies looking at a number of possible medications, and we don't know if they work until the studies are done. There's always a good rationale, but unfortunately, a lot of them haven't worked. For the latest infusion medicine that is going to be reported in more detail in a month or so, we really don't know yet, as the effect size for the primary outcome, as Dr. Yunus just said, is really small. In talking about significant, what investigators and drug companies mean is statistically significant, but that the statistics can be significant even if the actual difference is so small that it won't be noticeable. And what we're waiting for is to see what some of the other outcomes were from this study. It hasn't been reported. It hasn't undergone peer review. We're hopeful that there will be something quite impressive. The field needs this. We're desperate for it, quite desperate for it. But I don't want to throw my weight behind something where the effects are too small to be noticeable. And so we'll wait and see with our fingers crossed for something important to emerge from this. But if not this time, then perhaps later on next year or the year after. I know we'll get there at some point.
Great. And Dr. Henderson, this next question was for you. So this participant would like to know how many participants are actually currently enrolled in our study and offering their time, and some idea of the geographical locations of the participants in our research.
Our data management core would be able to give you exact numbers, so I'll give you approximate numbers. I think since the beginning of the center, we've enrolled about 500 people. A few people have moved away, a few people have passed away, and the number of people that we're actually following now is probably just under 400. Almost all are in California because, as all of you know who've gone through the procedures, the initial assessment takes a fair amount of time. It's done here in person. A few people have moved away. We try to follow them remotely. We try to make arrangements with other ADRCs and other locations. If someone moves to a state or a location that might be closer to a different ADRC. And the goal is to increase our total sample size over time to the extent we can logistically accommodate this to maybe about 500 and then sort of hold there. But we've just made great progress during the last 5, 6, 7 years, and I'm really pleased by everyone who's stuck with us during this time.
Okay. And then the next one we can have Jenny answer. So Jenny, do you have any kind of recommendations for some of the best senior activity centers? They didn't put a location, but we can assume maybe in the Bay Area for now.
Yes, there are quite a few. There's one very close to Stanford in Menlo Park called Rosner House. There's also in Mountain View, Avenidas. They have a day center there. Palo Alto. I don't know the best way to answer that. I don't want to single any of them out. There's quite a few though. You can, I hate to say this, but just do a Google search for adult day programs in Santa Clara County or San Mateo County. But the closest are probably Golden Castle, Rosner House, and then Avenidas Rose Kleiner Center.
Great, thank you. And then the next couple here, I think any neurologist can kind of answer first these. So this one is asking, can you see any relationships between pre-diagnostic history of major depression with various forms of dementia?
I think I'm going to jump in there because with colleagues, we're actually looking at this question. In terms of the biochemistry of depression, there are some neurons that are affected in depression that are also affected in Alzheimer's disease and also Parkinson's disease. And so there's always been the question about whether or not there's a biological overlap. And if someone has depression at one point in time, does that mean that there might be early Alzheimer changes going on? And the answer has never been completely clear. There's a clear association between having depression later in life and then developing dementia later. But is this because people are sort of aware of cognitive impairment and are becoming depressed? Is it because the parts of the brain that are implicated in depression are also implicated in early Alzheimer changes? Or is there some other relation? And so it hasn't been clear that the relation is causal. Some of the work that I'm doing with colleagues in Denmark suggests that actually depression in early life also increases risk. And so there may be that direct connection, although this study hasn't been published yet. And so I think there's a clear association and maybe even a link that's more direct than that.
Great.
Let me add one other thing.
Mhm.
We don't know yet that treating depression by itself will reduce the risk of dementia, but the implications are that it might. And so certainly people who have depression, I think it'd be important to try to seek professional guidance, not necessarily drug treatment, but anything that can help depressive symptoms will improve quality of life and, just possibly may help reduce dementia risk later on.
Great. And I think that's a good segue into one of these other questions for Jenny. So you mentioned person-centered care, and this person was asking, does a combination of person-centered care along with family-centered care provide the best outcomes for improved quality of life?
Yes, absolutely. Family-centered care hasn't really been looked at much in dementia care, unfortunately, although I hope that it does. I think that's seen more in pediatric care, but it's the same principle that those that are supporting the patient should really be part of the care team. And I'm sure we'll see more research on that in the near future, but using the term person-centered care, believe it or not, has actually come a long way in the past 10 years. That wasn't even really, we didn't focus so much on the person living with dementia as being a person. It was more looking at the disease. So we're definitely making steps in the right direction.
Great. And Dr. Yunus, this is following back on the statin question that we talked about earlier. Are there any connections to using statins and Alzheimer's disease that you're aware of?
I think the data is really contested there. It's not really clear. We're actually running a project to try to understand that. I think I personally don't think so, but I don't know, Dr. Grichus might have some thoughts on this as well.
Yeah, and Victor can probably weigh in also. I mean, my general take is if you need a statin for, reasonable indications, your cholesterol's high, you've had a heart attack, you've had a stroke, you should by all means be on a statin. I think their benefit against, for example, vascular dementia seems pretty clear to me. And, there's been a lot of back and forth about whether statins might actually protect against Alzheimer's. More recently, some question as to whether they might contribute to some memory trouble. But, from my perspective, if your primary care doctor has a good rationale to have you on a statin, you should be on a statin. And as full transparency, I'm on a statin. So I'm not just a member, I'm the president or whatever. Anyway, I think they're generally very well tolerated and really critical tool against cardiovascular disease and cerebrovascular disease.
And I agree.
Okay, great. Thank you. And then these next couple of questions, I believe, are from participants that we've had in our ADRC for a few years now. So this next one is asking if they will ever hear anything about the conclusions that we draw from all of the research that we collect.
I'll jump in here and say I hope that some of the conclusions you heard about were presented, that you heard some of the conclusions in the presentations today. I think the data that are being collected are just invaluable. And from Dr. Wilson, Dr. Gracious, Dr. Mormino, you heard about some of the things that are being done with these data, and there are a lot of other studies. But also, I would point out that the Stanford ADRC is part of a network of other Alzheimer's disease research centers supported by the National Institute on Aging. And a lot of data from all these centers is pooled together. There's a coordinating center in Seattle. There's a biospecimen center in Indianapolis. And through the contributions to these various collaborative research databases, we're able to advance the field in ways that don't bring direct recognition to Stanford, but where Stanford's contribution, like those of the other centers, cumulatively is really invaluable. And so a lot of the research that's being done is a little bit invisible because it's being done on a national level, but it's nonetheless very, very important.
Great. And I think this question is also from another participant that's been with us for a while, but they were wondering if it would be useful to have repeat current scans done of their brain to see if anything new is showing up. So if we have any plans to look at that.
I can field this one as a deputy director of the imaging course. So if I understand the question, it's whether longitudinal imaging would be helpful. Is that right, Lisa? Sounds like it.
Sorry, what did you say? Sorry.
Yeah, it sounds like the question is about whether follow-up imaging is helpful or useful. So yeah. Generally we do not just intend, but actually do repeat imaging on most, if not all, of our participants. The interval is the question. So for healthy controls, for example, in the ADRC, there's not a whole lot of change over a year, for example, or 2 years. But over 2 or 3 years, there may be changes. If the interval that we scan people again over varies a little bit by whether they have symptoms already or they're healthy controls. But we're also interested in repeat PET imaging, not just MRI imaging. So Dr. Mormino follows subjects that are in the center. And if they're amyloid positive initially, we probably don't repeat the amyloid PET scan because that doesn't change much, if at all. But the tau PET does change over time as symptoms progress. So we're definitely interested in longitudinal imaging. We do it if we haven't reached out to you lately. It may be because you've been scanned, within the last year or two. So there's a little bit of a interval between scans.
Yeah, it depends a little bit on logistics and on funding. So, for the kinds of imaging that Dr. Gracious mentioned, there certainly is or can be value in longitudinal follow-up. There is some logistics in trying to get new people and current people, scanned or followed up in scanning. And these are also expensive things to undertake. We've been very fortunate through the NIH, through the Iqbal Farouk and the Assad Jamal Fund, and through other sources through other people's grants to be able to fund a lot of the imaging. But it also depends a bit on our resources and the logistics. But over time, we do plan to repeat some of the scans, and I think the tau imaging would be one of the targets of that.
And this next question for anyone who wants to chime in is asking, do Valium or Ambien contribute to brain deterioration, and could they lead to Alzheimer's disease?
I'll weigh in, but I'd like to hear from Dr. Yunus and Dr. Henderson if they have different thoughts. So the way I view this is I don't think that Valium or Ambien or other sleeping agents contribute to the pathology itself. I think they can exacerbate symptoms for certain. We're not crazy about Ambien, particularly in older subjects. Clinically, there are a lot of sort of odd sleep behaviors that can result from using Ambien. So yeah, I think it's more what they can do in the short term rather than what they do in terms of driving, the pathology of the disease and increasing risk, for example. So we do our best to avoid them. We have some specific sleeping agents that we prefer over things like Ambien. when we really need a sleeping agent. But I don't think that they, drive the pathology itself. I don't know if Kiana or Victor feel different.
I agree. Ambien has been effective in some cases as well, where other medicines weren't, like especially after trying some medicines in very advanced cases. I thought was effective. So I don't personally prescribe it. I tend to use other medicines. But there is a list called the BEER list, the BER list, which has all the medicines that people over 65 should avoid. And we frequently see patients in clinic where they're on some of these medicines. So I think it's kind of good if you have questions about these medicines to check that list.
Great. And I think we just have one more question. And this is asking, are there some strategies or kind of what do you recommend to help slow or help someone with Alzheimer's for a person that's living at home alone or living with a partner? Just kind of daily habits that they can do.
I can take that one. Okay. I think Jenny gave a very nice summary of the things that we can do in terms of developing the care plan. And I think I'm going to kind of repeat part of the care plan. I think that you have to have a schedule for the patient, and also you have to review that the patient is taking the correct medication. You have to take care of the sleep hygiene, that the patient is sleeping the correct amount of hours during the night. And we also recommend exercise and taking a healthy diet. And I think all of these will kind of, some of these interventions like exercise or diet have shown that they will reduce the disease progression at some point, but there is a point when you're in mild stages, but when you're in moderate or advanced stages, that's more difficult, but at least it will maintain the quality of life.
Thank you. And Nusha, do we have time for a couple more that trickled in just now?
Sure.
Okay.
Yeah, we do. We have a good 10 minutes that we can keep asking questions because I think people will think of them. Thank you.
Okay. And along the lines of going back to Ambien and Valium, what are your thoughts on using melatonin? Are those similar as far as pathology or?
Let me start off and then hear what the other panelists say. It is different from Valium and from Ambien. So there's no similarity in that sense. It is like a lot of medications in that it has more than one effect. So it's used, of course, most often to try to regulate sleep-wake cycles, but also has anti-inflammatory properties. And in the animal literature, you can find almost anything that you're looking for. I think clinically, it's used a lot to help people with sleep. I don't know that the evidence in the setting of dementia is that good for it. I tend not to prescribe medicines unless I'm pretty sure they're likely to make a difference. But on the other hand, a lot of my colleagues do prescribe melatonin for patients with cognitive impairment or dementia who have difficulty falling asleep, and they may be able to relay some of their experiences. I don't think there have been any systematic studies done, however, in relation to melatonin and dementia.
To me, I think it's like one of the first, it's one of the ones with the least side effects. So I do try it first because it's mild and like less side effect profile, cognitively speaking. There's some data for REM sleep behavioral disorder or sundowning, but it's really controversial. It's like the problem with these medicines is that it's hard to run big trials because pharmaceutical companies won't fund them because they're over the counter. So I sometimes just kind of try it with the patient, see if they do better, if they respond better, and do it gradually, make sure that they're not groggy the next day, and then maybe find, and then, just like a trial basis.
And as Dr. Yunus said, the safety profile is certainly much better than with a medication like Ambien in this patient group.
And again, on the lines of sleep medications, Dr. Gracious alluded to some other medications that are better than Ambien. Do you happen to have any of those off the top of your head? They are?
Yeah, I actually, I thought I replied in the chat, but
Oh, okay,
for
sorry.
other people maybe didn't see it. You know, each of us have sort of different preferences. My sort of go-to medicine, if somebody really needs a sleeping agent, is trazodone, which is a kind of old school antidepressant with sort of mysterious mechanism of action, but that tends not to have a lot of carryover effects. So a lot of sleeping agents that people use will make them feel groggy the next day, like Dr. Eunice mentioned, or kind of hungover, and that can make memory look worse in and of itself. So, you know, certainly things like Ativan or Valium have that effect, and trazodone tends to have less of that. So I'll often turn to trazodone at a low dose to start, like 25 milligrams as needed for sleep. Remeron is not the one that people like.
And I wonder if Dr. Abdelnour, whose training has been in different places, whether there are other perspectives that you have on this?
Well, we use trazodone too. We usually use melatonin. We can often start with melatonin, and if the patient presents REM sleep behavior disorder because it has Lewy body disease, we usually start with ribotril. That is, yeah, clonazepam, right? I always miss that. Yeah. Alprazolam too, but it's short action, so we don't use that much. We try to avoid the benzodiazepines.
Yeah, that's actually a really important distinction. Thanks, Dr. Abdelnour, for bringing that up. So the one place where we're actually fine with people being on things like, well, clonazepam is the most commonly used for this, is patients with Lewy body disease or Parkinson's disease who have really bad REM sleep disorder and act out their dreams and throw themselves out of bed or hit their partners. Medicines like clonazepam can be very helpful. So, but for standard sort of Alzheimer's disease, insomnia, we lean away from medicines like clonazepam or Valium.
Great, thank you. And thank you everyone for your questions. I think we were able to get through all of the questions, so that's great. So I can hand it back to Nusha.
Were we able to also get the ones that were pre-submitted?
Yep.
That were, okay, perfect. Thank you so much. Well, I have a few things to say, and then I'd like to go ahead and let Dr. Henderson close the session, the event today. Again, I really want to sincerely thank all of you, our participants, the families, the care partners, you know, whoever is part of your village. And then in turn, you are all part of our community. So we greatly appreciate your generosity of time and spirit and other offerings that you provide to the Stanford ADRC. I also would like to ask all the participants to please make sure you go ahead and fill out the survey, which is the same link that was at the bottom of your agenda that we sent, through which you registered. It's actually, I did put it into the bottom of the agenda that you were sent. So if you would kindly take the time to give us your feedback and let us know of any, you know, suggestions, or also if there are other topics for future events. Again, my sincere apologies for the technological issues and snafus, but we really hope that you were able to enjoy the session today. And then sincere thanks also to all of our speakers. Thank you for your generosity of time and sharing your knowledge and wisdom with all of us. Drs. Kian Eunice, Dr. Carla Abdelnour, Jeff Nerschel, Ted Wilson, Beth Mormino, Mike Gracious, Jenny Clark, and Dr. Henderson as well. And last but not least, my sincere thanks to the entire team behind putting this whole event together. Again, I want to sincerely thank Isabel, Talisa, Veronica, Nicole, Nora, Maria Lucia, Gabriel, Mohini, Alejandra, whom you hopefully interface with when you come into the center or through the follow-up visits. And then also Alyssa Anderson, who kindly was helping with a lot of these technological issues. So again, many thanks. Everyone be well, keep well. And we sincerely are hoping to see you all in person next year. So let's work towards that. Most likely we'll try to make it hybrid for those who might be further away, etc. But as many of you who can make it in person, we sincerely look forward to seeing you at the next event next year. Dr. Henderson, if you have anything you would like to share with the group.
Very little. In your survey response, if you might add in, if there's no other place to put it, whether or not given, let's say, a level of COVID concern similar to what it is now, whether you would feel comfortable attending in person next year. I think, as Nusha said, we would like to have some of this in person, perhaps a hybrid session, but let us know whether or not you would feel comfortable in coming in person. That would help us in our planning and thinking about how best to present everything. My apologies for not being able to join fully, but I'm so grateful to our researchers, to our staff, to Nusha and Isabel and to Lisa for helping everything run smoothly here. And I'm especially grateful to all of our participants and their family. Thank you for coming. Let us know if you have other questions, how we can help, and we look forward to seeing you next year.
Thank you, everyone. Bye-bye.
Thank you, everyone. Be well. Take care.